Good afternoon, and welcome to this second day of our two-day public workshop on reconsidering mandatory opioid prescriber education through a REMS in an evolving crisis. The Duke-Margolis Center for Health Policy is convening this open workshop under a cooperative agreement with the U.S. Food and Drug Administration. I'm Mark McClellan. I'm the director of the Duke-Margolis Center. I'm also an independent member of the boards of directors at Cigna, Johnson & Johnson, Alignment Healthcare, and Prognom IQ. And on behalf of my Duke-Margolis collaborators and FDA, I'd like to welcome all of you to this second day of the workshop. This meeting is bringing together a broad range of expert perspectives, along with opportunities to hear questions and comments from all of you to inform FDA's ongoing considerations as to the role of continuing education through the opioid analgesic REMS. We got a great start on these issues yesterday in the first half of this meeting. We began with a series of presentations. I think this is on the next slide. We began with a series of presentations from FDA and NIDA, giving us some historical context to get up to speed on the ways in which the opioid and substance use crisis has evolved over the past decade or so, leading to this present moment. Wilson Compton of NIDA shared valuable background on the history of the opioid and substance use crisis, including the shift that's occurred towards more polysubstance use and stimulant use driving rising overdose deaths along with opioids, and some ways in which the pandemic may have contributed to increased risks of opioid use disorder and overuse and overdose deaths in the past year and a half. Then Doris Auth laid out some of the research and decision-making process that led to the current opioid analgesic REMS and the REMS goal of reducing adverse outcomes like addiction, overdose, and death related to prescription opioid analgesics. Completing this set of overview presentations, Corrine Woods reviewed how prescription opioid utilization has been declining on average in recent years in terms of total prescriptions dispensed, number of new prescriptions, and the length and strength of those prescriptions. We then moved into our first two panel discussions, where we heard from panelists about the current landscape of provider education efforts and how prescriber education might be able to support our response to this current crisis. Our first panel then took an overview of the landscape of the current provider education efforts at the federal, state, and health system levels. We heard some great points on how to make education effective by really engaging providers and tailoring programming to their context, as well as some concerns about industry messaging in educational content. Then, to close out the day, our final panel echoed some of those points about how to engage providers and encourage real change through educational messaging, in contrast to what some felt could be burdensome, not well-targeted, and ineffective programming if it's not executed correctly. We also had some great discussion around the goals and the role of continuing education, how it has to strike a balance between reinforcing fundamentals and translating new developments and best practices into the very real context in which diverse prescribers are actually practicing. Now, on our next slide, I want to look ahead to today's panels. We've got two more panel discussions as we continue to focus in on how REMS education can best function to mitigate the current opioid crisis. The first panel will consider the future role of federally mandated prescriber education, including but not limited to the potential challenges associated with mandatory REMS education, as well as the potential benefits of such a requirement. And then to conclude our event, we'll have a panel on next steps, which will bring together a range of perspectives on lessons learned throughout these 2 days and discuss what the implications might be for opioid analgesic REMS. So on the next slide, I'd like to turn to the Statement of Independence supporting this work. The Margolis Center for Health Policy is part of Duke University. As such, we honor the tradition of academic independence on behalf of faculty, scholars, and all of those participating in our programs. Neither Duke nor the Margolis Center take partisan positions, but individual members are, of course, free to speak their minds and express their opinions on important issues. Also add that the conversation today, while supported through a cooperative agreement with the FDA, is not a federal advisory committee. There won't be any votes. There won't be any specific efforts to seek a consensus or particular recommendations. It's a success if we get a wide range of perspectives out for discussion. Now, I've got just one final set of points on the next slide. I want to encourage attendees to contribute to the meeting through the Zoom Q&A function. We had a very lively dialogue there yesterday with many comments and questions raised, which we were able to address to some extent in the sessions, and our panelists were very generous in responding to directly. So I want to build on that in today's meeting. Please don't hesitate to submit through the Q&A function. We'll also, again, try to bring some of these questions into our panel discussion. So please feel free to pose those as well. And whether you submit to the Q&A function or not, please remember that FDA has established a docket to receive input from stakeholders on the types of issues that we are discussing in this meeting. And as a reminder, again, that docket is open until December 3rd. The link to the docket is in the Federal Register notice for this meeting. And finally, just a reminder that while there are many interventions implemented to promote the safe use of opioids, this convening is focused on the key issue of prescriber education. We had some great discussions yesterday about prescriber education that appropriately and understandably place those discussions in the context of the many other issues and policy interventions that surround and create an environment in which prescriber education occurs. So I'm sure that'll come up again today. Encourage you to keep your comments centered on education requirements and trainings. I do expect to see more opportunities from FDA to hear input on these other key issues related to the opioid and substance use crisis and how to respond to it. And it's certainly a high priority for our for the Duke Margolis Center for Health Policy as well. So thank you all for joining. I'm looking forward to a very productive and engaging time together. And I'd like to turn now to Dr. Marianne Hamilton Lopez, the Senior Research Director of Biomedical Innovation at the Center, to moderate our first panel.
All right. Thank you so much, Mark. I'll start by introducing this session's panelist. As you can see from the title, we are going to be considering the future role of federally mandated prescriber education in alleviating the current opioid crisis. I'll be joined by Bobby McConnell, Chair of the American Medical Association Board of Trustees and Chair of the AMA Substance Use and Pain Care Task Force. Elise Powell, State Opioid Coordinator for the North Carolina Department of Health and Human Services. Anu Rayo Patel, Physician Member, North Carolina Medical Board, and Steve Singer, Vice President of Education and Outreach at the Accreditation Council for Continuing Medical Education. Thank you to all of our panelists for joining us today. We've asked that each start with some opening remarks, and I'd like to begin with Bobby.
Greetings. On behalf of the AMA, thank you for the opportunity to provide comments on the issues under consideration here. My name is Bobby McConnell. I practice otolaryngology in Flint, Michigan, and chair the AMA Board of Trustees, as well as the AMA Substance Use and Pain Care Task Force. And other than performing one of the most painful surgical procedures known to mankind, tonsillectomy, I have no other conflicts of interest. Next slide, please. It bears repeating that the nation's overdose epidemic has become worse. We know the data show how the epidemic has changed from one where the majority of death was related to heroin and prescription opioids to one where the mortality related to illicitly manufactured fentanyl, fentanyl analogs, methamphetamine, and cocaine became the primary drivers. Mortality related to heroin and prescription opioids remains far too high. However, millions still do not receive treatment for a substance use disorder, mental illness, or pain. We have a major non-medical use problem. The National Survey on Drug Use and Health has reported for years that 60 to 70% of non-medical use of opioid analgesics is due to stolen or given away pills. The AMA does not believe that a mandatory opioid prescribing REMS will reduce mortality diversion, or improved patient care. The mortality is not being driven by prescriptions. Thus, we need to look at the true problem: illicit use and substance use disorder. Next slide, please. The most common policy interventions across the country have been mandates to restrict opioid prescriptions, mandates to use PDMPs, and mandates to take a few hours of continuing medical education on pain, prescribing, substance use disorders, and other related areas. Mandates for continuing education, as the FSMB has told us, range from 1 or 2 hours per licensing cycle to a one-time 12-hour requirement in California. In Michigan, where I am, the 2018 CME mandate says that every 3 years, I have to take 3 hours out of 150 in pain and symptom management. I prescribe very few opioids before the mandate and CME, and I prescribe about the same after. CME mandates don't remove the administrative barriers to treatment for mental illness or substance use disorder, or allow us to focus on increasing equitable, affordable options for patients with pain. Data from the CDC and other sources show no correlation between CME mandates and reduced mortality. For example, illicit fentanyl began to sharply rise in Michigan in 2014, 2015. By 2016, mortality related to prescription opioids had begun to plateau, but heroin-related mortality continued to increase. Around the same time, illicit fentanyl became the main driver of drug-related mortality and is now more than triple either heroin or prescription opioids. In the past decade, opioid prescriptions decreased by more than 55% in Michigan. And if you look at nearly every other state, it's the same story. Reductions in opioid analgesics and CME mandates have not led to reductions in mortality or improved outcomes for patients with pain. Basically, despite physicians' efforts, the numbers are getting worse. Some national data: between 2011 and 2020, opioid prescriptions decreased by 44%. During the same time period, MME from these prescriptions decreased by more than 55%. PDMP use nationally increased from 61 million queries in 2014 to 910 million in 2020. And naloxone prescriptions have seen an increase from 40,000 to well over 1 million. These are positive trends. However, they have not, unfortunately, reversed the trajectory of the pandemic. Next slide, please. To be meaningful, education must be specific to a physician's clinical practice and patient population. The AMA, through our journal JAMA, our education hub, and our task force, provides access to hundreds of educational resources that are specialty specific. We support the prescriber's clinical support system and the Foundation for Opioid Response Efforts. Physicians continue to educate themselves through these many avenues. Education provided by medical societies has increased from courses and materials being accessed about 120,000 times per year to just a few years ago to several million times a year now. And as the data have shown you make clear, we do not have any reason to think that a lack of sufficient education about prescription opioid analgesics is the reason that the drug overdose epidemic has persisted and gotten worse. Other barriers have made it significantly greater impact. Health insurance prior authorization requirements, narrow networks, and coverage denials are preventing patients from getting the treatment for substance use disorder that they need. Teaching me the right thing to do is not helpful when I simply can't get the right thing done due to these barriers. By further stigmatizing opioids and patients who rely on them, a mandatory REMS program is likely to exacerbate these problems. Let's remember that opioid prescribing reductions began in 2011, 2012, and continue in every state, whether or not there's an opioid prescribing restriction or CME mandate. The AMA task force recommended that if an opioid analgesic was clinically indicated, that we should prescribe the lowest effective dose for the shortest clinical duration. Physicians embrace this approach, as have many health systems and private practices. Through internal review procedures and academic detailing programs, physicians and health systems review prescribing patterns in a non-punitive way to learn why some are outliers. The discussions for OB, general surgery, neurosurgery, ENT are all different, as we would expect, because the circumstances are different. A mandatory REMS would not be able to address these important clinical differences. Even within a specialty, it's tough. If I'm an otolaryngologist doing a lot of head and neck cancer surgery with painful treatments, my data is going to look a whole lot different than if I was an otologist doing mostly micro ear surgery. Next slide, please. Rather than a mandatory REMS, there's a greater need to support GME programs to hire core faculty in pain medicine and addiction medicine, as well as psychiatry, as we heard yesterday. We applaud the FDA's efforts in their approval of higher dose naloxone formulations. It doesn't remove the need for community-based affordable naloxone, but it's a huge step forward. The AMA strongly supports the FDA's efforts to make it easier for naloxone manufacturers to submit OTC applications. We urge the FDA to review labeling for buprenorphine to account for the need for higher doses in response to illicit fentanyl. We urge the FDA to support efforts for medications to treat substance use disorder related to methamphetamine and cocaine. We support efforts to remove arbitrary thresholds to the 2016 CDC opioid prescribing guidelines. And finally, the AMA stands ready to work with the FDA on education efforts targeted at employers to help destigmatize medications for pain and substance use disorders. We're doing that now with the DEA and would gladly support partnering with the FDA to increase access to evidence-based care for patients with pain. Next slide. So thank you very much for this important and enlightening conversation yesterday and anticipated today, and looking forward to the dialogue.
Wonderful. Thank you so much, Bobby. Next, we'll turn to Elise.
Hello, and thank you all for joining us today. So I am going to talk about specifically North Carolina's perspective, not just an opioid epidemic response, but particularly as we think about the considerations for a federally mandated prescribing education. I wanted to share some of the lessons that we here in North Carolina have learned implementing our own educational efforts in response to the opioid overdose crisis. So through my time, I'll contextualize a little bit. I know folks covered this yesterday at the federal level, but a little bit against what North Carolina is seeing in terms of its own overdose crisis, and then how that's informed our prescriber education efforts and the lessons we've learned that might be informative for this conversation. So go ahead forward. Oh, next slide. So North Carolina, similar to the national trends, has seen a pretty large surge in overdoses during the COVID-19 pandemic. We actually, through a ton of hard work by many, many incredible partners across the state, just prior to COVID, had been finally starting to bend the curve, where we were seeing our first ever declines in opioid overdose related emergency department visits in 2018 and 2019. But unfortunately, North Carolina, like the rest of the nation, saw a big increase in overdoses through COVID-19. Next slide. Now in North Carolina, heroin and synthetic narcotics like fentanyl, carfentanil, those kinds of analogs are still the primary driver of overdoses in our state. But we, similar to the rest of the nation, are seeing increases in overdoses involving cocaine, benzodiazepine, psychostimulants, and we are seeing declining overdoses involving commonly prescribed opioids. Next slide. So, when we're really talking about our overdose crisis, similar to what Dr. McConnell said, right, we really are talking about an opioid overdose crisis that's really primarily driven by illicitly manufactured drugs. Next slide. And, it's really important to emphasize that long gone are the days when we sort of talk about an opioid user versus a cocaine user versus someone who might be struggling with benzodiazepines, right? We really need to start thinking about not just one substance or another, but the root causes of addiction and the disease of addiction. And, nothing shows that data more than sort of the increase of polysubstance use. Here in North Carolina, more than 61% of overdose deaths involve multiple substances, right? So even when we say opioid overdoses, we're not just saying opioid overdoses, typically other substances are involved. And I particularly wanted to call out, since we're talking about prescription opioid overdose deaths, that even though prescription opioid overdose deaths they're declining but continue to be a problem, 82% of those deaths involve other substances, right? So we're not talking about someone who's just overdosing on their own pain medication, but rather a combination of substances, even for those deaths that still involve prescription opioids. Next slide. I also really want to point out that we are struggling very badly with a heavily contaminated supply. So in addition to polysubstance use, folks using substances in combination either knowingly or unknowingly, North Carolina and the rest of the country is struggling with a huge, and this really increased during the pandemic, a huge number of contaminants entering the drug supply. So for example, we're having a giant problem with xylazine, which is a veterinary tranquilizer, showing up in a large number of samples that get tested. We're seeing a lot of emergency department visits related to that. In addition to it being very dangerous, it can cause large open lesions, niacin, several other supplies. And so when we think about the pandemic, the epidemic in front of us, right, we're dealing with not just a transition to polysubstance use, but also a supply where people simply just don't know what's in it, and there can be a lot more dangerous substances. Next slide. So North Carolina's response to the opioid epidemic broadly is guided by our strategic plan, the Opioid and Substance Use Action Plan. We actually just updated it this June, and it really lays out 3 pillars of response. Prevent. So obviously we want to prevent as many people from struggling with addiction as we can. Reducing the harms associated with drug use, and connecting people to care. And if you tap forward one on the slide, really where our provider education efforts live is in 2 places within the strategic plan. Under our pillar of work that's around reducing inappropriate prescribing and expanding pain management, because we know we need to do both, and expanding access to substance use disorder treatment. So a lot, and I'll speak about this in just a moment, but particularly as we move to an overdose crisis that's really heavily driven by heroin, by fentanyl, by many substances in a contaminated supply, we've really been heavily focusing on making sure that there are enough addiction treatment providers out there, and there are enough providers who are knowledgeable in addiction to be able to prescribe MAT if they so choose, who know how to identify addiction and refer appropriately. And so I think that's a really critical piece of the puzzle. So going first to the next slide, I'll talk just quickly about some of our prescriber education efforts. And when we think about our prescriber education efforts, I really think of education in terms of moving from broad to deep, right? Our broad efforts reach many, many people, but the depth of information is usually quite shallow, all the way down to efforts like academic detailing and peer-to-peer learning, which are incredibly powerful for behavior change, but also incredibly resource intensive. And so not something that you can easily do at a really wide scale. And we've done interventions at all of these levels. So, looking at the sort of broadest category first, we've done a huge amount of education in relation to the STOP Act. So that's North Carolina's law that implemented certain guardrails around prescribing opioids in certain acute settings. We actually just implemented the last requirement of the STOP Act in this July, which involves mandatory checking of our PDMP. And so we've been doing a large amount of communication and outreach around, hey, you have to check you now are legally required to check the PDMP before you prescribe these controlled substances. If you want to learn more about safe and healthy prescribing, here are all of these resources. We launched the North Carolina Dental Opioid Action Plan. So we had a lot of data that showed that a lot of our now new opioid prescriptions, so people who are opioid naive and receiving opioids, were coming from dentists, and so launched a whole dental opioid action plan. Worked really closely with North Carolina Dental Association and others to launch that plan, with specific strategies that they could do. And a lot of that did involve a broad education of dentists practicing in North Carolina. We also, through a partnership with the Governor's Institute here in North Carolina have trained more than 4,000 prescribers in the state on topics including safe opioid prescribing and how to do judicious opioid pain or opioid sparing pain treatment, right? And so we really have, put a lot of muscle into these kinds of wide sweeping, broad educational efforts. The one that I'm really excited to share with you all is more data-driven outreach, right? So PDMPs are really powerful tools. And one of the things we do with ours is leveraging the PDMP to flag aberrant prescribing or what we call unusually high prescribing, right? So there's a series of automatic flags set up within the PDMP that, triggers indicators that there might be some aberrant prescribing or some incredibly high prescribing. And that then alerts the appropriate medical or licensure board of this person. It is not a very punitive approach. Our goal is not to, come down on people and say, we're going to take your license and blah, blah, blah. It's to sort of reach out to North Carolina Medical Board, the Board of Nursing, whomever, and say, hey, it seems like it's worthy of a conversation with this prescriber. And I think this is a really, really important approach with a lot of lessons learned, because the reality is, right, it's not a mystery of who are our high prescribers in the state. We already have the data to tell us that. And so I think, being data-driven and data-informed in our educational efforts can really help us connect the right message to the right person. The other piece of the puzzle that I think is just so critical when we're thinking about prescriber education is thinking about our training curricula, right? So what are the standard curricula that are being taught in medical schools, in residency, in advanced practitioner training programs? Here in North Carolina, we feel very strongly that just like every medical student has to learn about diabetes and other chronic illnesses, every student who gets a medical training should have to learn about addiction. It's a chronic illness, right? They will likely interact with patients experiencing addiction in some form or flavor, regardless of where they practice. And so we launched an MAT residency training program, which not only got the full buprenorphine waiver training to more than 1,500 prescribers across the state, which is just huge for here in North Carolina, but it also incorporated MAT training, which includes both the MAT waiver, and the basics around addiction, into over 29 residency and advanced practitioner programs. So that means that that's going to be an ongoing part of their curricula going forward. And now 4 out of North Carolina's 5 medical schools also have included that same training into their curriculum. So when we think about sort of creating a system of care and provider education, right? Like thinking about what we're including in that residency training, I think is so critical. And then of course, we have piloted academic detailing with high opioid prescribers. Again, I think one of the key lessons learned there is it's great for behavior change. You can go super deep with individual prescribers, but it's really hard to sort of affect change on a mass scale. And then promise my last slide is next. Want to flip to that. So thinking through, the lessons we've learned here in North Carolina and how that might inform some federal considerations. One thing that we have found across all of these efforts is that you really have to align the correct message from the correct messenger if you want behavior change, right? We can, here in North Carolina, we can shout education and continuing eds, forever, but if it's not from a trusted source, a board that is sort of recognized by the provider, it really doesn't go far in terms of behavior change. So really thinking about right message and right messenger is so critical for the success. As I spoke about, you can go broad, you can go deep. We have found the most success with ones in the middle, right? Where it's not the very broadest, because those tend to not be great for behavior change, but really ones where we can be data-driven, we can be thoughtful with where we're engaging. As I mentioned, the changing educational curricula has been hugely successful for us. I think that's something that I'd like to see replicated elsewhere. And finally, just to sort of shout out that PDMPs are a heavily underutilized tool when it comes to provider education. As I said before, the reality is, right? We know who the high prescribers are. That's information we have. And so how do we think of tools like PDMPs and prescribing data to really target education to where it needs to go? So I know I'm a little over my time, and thank you so much all.
All right, thank you so much. Next, we'll turn to Anu.
Yes, thank you. And good afternoon, everyone. Thank you for having the North Carolina Medical Board here to offer comments on this important topic. I'm Anu Rao Patel. I'm a physician. I'm honored to be a board member of the North Carolina Medical Board. My background is in physical medicine and rehabilitation. Before I get started, I have no conflicts of interest to disclose. So I will be speaking to our approach in engaging medical professionals on opioid topics. If we can move on to the next slide, please. So really, when we look at the role of the regulator, by design, we are not activists, or for that matter, we don't serve as advocates the way that perhaps a specialty society may serve. And we are obviously not involved directly with patient care, right? This is the job of the individual medical professional. So really, a regulator's role is focused on applying and enforcing existing standards, not so much creating new ones. This certainly doesn't mean that regulatory boards can't influence the quality of care or provide leadership. It just means that in the event that we do so, we have to be thoughtful about how and when to intervene. If we can move on to the next slide. You may have to click one more time. Perfect. So the North Carolina Medical Board actually uses its megaphone a lot to talk about opioids or really any subject of interest or importance to our licensees. We see good communication as really the linchpin of being proactive, a proactive regulatory body that provides value to licensed professionals. So when we think about licensed medical professionals, in terms of practice of medicine, they really have to comply with numerous laws, rules, policies, and really as a service to our licensee, we routinely circulate information about impending requirements and really try to serve as a resource. Certainly the North Carolina Medical Board is not obligated to do more than notify and when appropriate, identify and address non-compliance. However, we believe that it benefits both the public as well as the profession when medical professionals stay well informed. And this, of course, is under the key assumption that most licensees, when given good information, will comply. And this view really informs much of the board's overall communications strategy. If we can move on to the next slide. So really, what are the tools that we utilize? The North Carolina Medical Board utilizes some or all of the tools listed here to raise both licensee and stakeholder awareness of opioids and related initiatives. So we might actually put a notice or a visual slide on our North Carolina web homepage. We have a newsletter, so we might actually put out an article. And this actually remains our best vehicle for reaching a large number of our licensees. The newsletter is called The Forum, and really we're guaranteed to get thousands or even tens of thousand eyes on important content through our newsletter. Social media posts, similar to other agencies, we are active on Facebook, Twitter, LinkedIn. We actually reach the most of our medical professionals through Twitter, and we will refer followers to content either on our own website or other high quality resources from other organizations. We have a dedicated resource page, so we've actually made use of these sort of dedicated web page to promote specific opioid topics. So, for example, we have a general safe opioid prescribing page. We have a page on the controlled substances CME requirement, which I'll talk about in a few seconds. We also have links to free and low cost courses. We have a page on the state PDMP, which Elise just mentioned in her talk. We also have a page for medication-assisted therapy where we link content and collect online and local MAT training opportunities. And really the resource page, what we do is we give it something called a vanity URL, so it's really easy to remember. So for example, the website link may be ncmedboard.org/MAT so that it's easier for licensees to remember. Back in 2020, we launched a new podcast called MedBoard Matters. And this is really for high profile topics such as new mandates, important deadlines. Elise mentioned the new requirement to check the state PDMP. So we use this vehicle podcast as a way to get out our information to our licensees. And actually, we looked at our data, and in July 2021, it was actually one of the most listened to episodes of the year was regarding the PDMP requirements. Another important part of our communication strategy involves contacting shareholder groups and asking them to include short articles on specific topics, either in their newsletters or email communications. This really helps us collaborate with other stakeholders and magnify our messages. We realize also that our licensees may sometimes be more receptive from content, specifically from their medical societies and specialty societies, as opposed to a regulatory board. And again, development of original and new resources. I'll talk about that shortly. Not on this slide, but certainly in our toolbox is something called an email blast, which we do to our licensees. We try to use this very sparingly. We certainly don't want to clog up people's email. We understand that people get a lot of email from many different sources. We don't want to, of course, be accused of spamming our licensees. We realize the more email you send, it's more likely to be deleted. So we try to reserve these email blasts for topics of critical importance or something that's very urgent that's going to affect a large proportion of our licensees. Okay, if we can move on to the next slide, I'll talk about the North Carolina Controlled Substance CME mandate. For those of you who attended yesterday, you heard from the FSMB, which is the Federation of State Medical Boards, about the number of states where medical boards had mandated CME around opioids. So for us, this was the first ever subject-specific CME mandate in North Carolina history. We certainly expected pushback, and while some licensees did voice an opinion about the mandate, a surprising number of licensees expressed relief that the medical board was actually addressing responsible opioid prescribing and felt that it was needed to improve both patient care and safety. We were very thoughtful about how we designed the mandate. We did not want to needlessly burden our licensees. And since many other states and organizations required controlled substances CME, we decided to allow our prescribers who had completed this opioid specific CME, let's say in another state or with another organization, to satisfy their NC requirement instead of having them do an NC specific course. Also, I'll mention briefly that we made this requirement as part of their overall existing CME requirement. So for example, with physicians, they require 150 hours over 3 years. So 3 of those hours were dedicated to opioids, and for PAs, it's 2 hours. So we didn't increase the total burden for CME. We tried to make this inclusive of the existing CME requirement. And I'll just wrap up with 2 more slides, and then I know I'm getting at time. In terms, if we can move, okay, thank you. In terms of supporting the medical board's requirement, CME, like we just heard on opioid prescribing, is abundant. And we're certainly confident that licensees are able to easily find courses to satisfy the NC CME requirement. So in order to ensure success, we actually developed CME for the first time in medical board history. We had a webinar, which was an hour, and then there was a panel discussion, which was from practicing physicians and APP providers. So if they were attending this, they would earn enough CME to fully satisfy the NC requirement for that CME cycle. And again, these are free. We actually even provided dinner for the panel discussion. And by the end of 2018, the webinar had actually been viewed more than 5,500 times, and we had more than 2,100 prescribers attend these panel sessions. So if we can move on to my last slide. Thank you. So I'll wrap up my comments with this final slide. And yes, all you see is a number. When we speak about impact and we talk about data, the medical board has not sought to measure specifically the impact of the controlled substances CME requirement. We have, however, asked our licensees about the impact of opioid overdose crisis on their practices. And it's important to take stock of the current situation before we implement any new requirements or mandates. So what does this 43%? I'll give you some quick context. We engaged a polling firm to survey our licensees in 2018. We had more than 2,600 responses. We asked whether the opioid overdose crisis had affected their practice. 58% indicated yes. The affected licensees were also asked, what actions have you taken in response to the opioid overdose crisis? And as shown on the slide, 43% of affected licensees had said that they had either stopped prescribing opioids entirely, ceased treating chronic pain, or greatly reduced their opioid prescribing. And although this is a relatively small poll, given the amount of folks we actually license, and I would hesitate to use this as a finding, evidence of a trend, but I would certainly say it's eye-opening because it validates calls and inquiries that we get at the medical board from pain patients who report losing access to care and difficulty finding a new treating provider for their chronic pain. So I would just encourage the FDA to be aware of any additional mandates or attention that could drive more prescribers from wanting to treat chronic pain and manage this condition. And it's also important to note, which I'll say as my final comment, that the most common response among our licensees was that they
I think we lost Anu at the end, and it was the final comment there. So I
provide comment.
All right, Anu, we lost you for just a moment. Can you tell us what was the final part of that sentence, the first part?
Yes, you were talking about when I had the slide of 43%. I apologize. I just noted that a lot of our licensees, both in response to the measures they had taken in their practices, had noted that one of the interventions they did were to seek out additional training and education to both improve their prescribing and their quality of care.
Perfect. Thank you so much.
Thank you.
All right. Last but not least, I'm turning this over to Steve for your comments.
Thanks, Marianne. Can you hear me okay?
Ken.
All right. I'm not a sports guy, but the bases are loaded. So I'm hoping to bring this home. I'm really very grateful for the privilege to be part of this this meeting and the panel today. And I also want to, hopefully in the next few minutes, build upon the conversation yesterday, which was just terrific. I am not going to be making any recommendations about patient care or products or services. So I have no conflicts of interest to report. And before I get started, I want to draw your attention to the title, supportive educational engagement. I was just looking back at the questions, the discussion questions that we were provided from the FDA. And I'm hoping that my presentation addresses the question of what are unmet needs? What are some ways that we can more effectively measure our impact? What lessons have we learned from the REMS educational program so far? And also to try to draw a picture of an ideal future. Next slide, please. So really trying to pick up on where Graham McMahon, ACCME's, our CEO, spoke about yesterday. ACCME, together with a number of other continuing education accreditors, have been sort of an integral partner in the REMS continuing education approaches of the last several years to provide a framework for independent education. But also importantly, I want to draw your attention to this, to provide data systems that allow us to engage interprofessional learners from not only physicians, but other professions who are being provided education from an educational provider. Accredited provider here is not a healthcare provider, but rather a healthcare organization that's accredited within our continuing education system. And we have data systems which then not only track what that education was, what parts of the blueprint it addressed, et cetera, but also pass that data along to licensing certification boards and also create sort of a personal transcript for the learner themselves. Next slide. So in my talk today, what I want to do is sort of expand the left part of this picture, because it is the patient who is at the center of our focus. I love the model, the strategic model that Elise provided about their strategic plan. So if we expand from the patient we recognize, and this was a main takeaway from yesterday's conversation, that the patient, you have patient-specific needs that are contextual to environment, comorbidities, the increasing sort of diversity and complexity of substance use and polypharmacy, et cetera. You have the clinicians, physicians or advanced practice nurses and others who are working with them. That is within the healthcare team. And then of course, within a system, a local system, a regional system. And I think it's very important for us to focus on this, to recognize that there is an enormous complexity, heterogeneity of the environments in which health professionals are working. Next slide, please. So I think an unmet need or an unmet opportunity is that, as we described yesterday, Kathy Chappell's comments had a great cartoon on this. One size fits all education is simply not going to address all these needs. However, we do have this opportunity that from each of these stakeholders on this figure, we can identify gaps, things that should be happening that aren't happening. We can address or identify educational need. What is the reason? Why don't they happen? And those inputs can support continuous improvement that ends up being sort of a vector of very specific direction related to the unique setting, practice, and patient population for each learner, for each clinician, for each system. Next slide, please. This then provides an opportunity for those gaps and needs to inform, and I apologize for my graphic skills here, but this arrow you'll see is sort of brushing past the certifying boards and the state licensing boards in order to create a living, breathing input to our regulations and into our requirements, so that gaps and needs inform an evolving set of skills, competencies, educational priorities, which are supported by regulations. But you'll see that the net direction of the information flow is coming from the place of care and into regulation, as opposed to the other way around. And you know, we can talk about that there are some challenges in this sort of ideal picture. But let's go to the next slide. So when we look at what is the educational activity in our continuing education system, we, ACCME, on behalf of the opioid REMS that we, together with several other continuing education accreditors, are again a supportive partner of from a engagement, educational provision, and data standpoint. We are publishing regular updates, and Graham shared one of those updates yesterday in terms of a link to the resource on our website. You can go on our ACCME website and search for these reports. But what you see in the first row is for the OA REMS education that engaged 109 educational providers. This is 109 educational institutions that generated 892 educational activities that reached nearly 400,000 learners. And that's not a small number. That's a terrific impact. But if we search our database, our activity database within our CE system, of how many accredited providers out of the 1,800 accredited organizations that we accredit, how many of them did education related to any of these keywords that are on the left-hand portion of the slide, and we look at the number of activities and the number of these are physicians and non-physician learners that were engaged, we see that the nature of the REMS is addressing a small part of a much larger environment. And I think that there's an opportunity there. Next slide. So we, together with our colleagues, published in 2019 kind of a lessons learned and ideas for the future paper about our experience with the REMS continuing education program. This is a summary. I don't need to address each of these, but you'll see that there's sort of a theme through these points, which is about helping to move us from a one-size-fits-all to something which can live, breathe, evolve, and meet sort of the ever-changing educational needs and gaps that we see within our learners and within our healthcare environment. Next slide, please. Kathy Chappell, who's my partner in crime, together with Eric Holmboe, in leading the education and training work group of the National Academy of Medicine's Action Collaborative on countering the opioid epidemic, mentioned yesterday that we're just about to publish a special publication based on our work within our working group. And if you click on to the next slide, Kathy shared this yesterday. The mission of our group was to try to identify a way to increase collaboration and develop a harmonized interprofessional, patient, family-centered approach across the continuum of health professions education to address these important issues. And the publication that is due to come out in November, we took a look at the literature about what is known across professions relative to professional practice gaps, existing regulatory requirements and policy standards, and then from that analysis, develop some actionable priorities. Those priorities are summarized on the next slide. And this is really kind of a picture of future opportunities, and several of these are underway. So Kathy talked yesterday that we are already working collaboratively to develop a set of minimum core competencies for all healthcare professionals in pain management and substance use disorder, and working with regulatory agencies. And the speaker from the Federation of State Medical Boards yesterday talked about their involvement in this in terms of a interprofessional collaboration to align accreditors' expectations in interprofessional ways, to foster collaboration around interprofessional optimization of regulatory approaches and outcomes between licensing certifying bodies. Very importantly, to unleash the opportunity for continuing education to provide this sort of individualized, sort of practice-based, important continuous improvement and learning specific to the problems and the system issues that they have locally. And then lastly, to facilitate collaboration that would harmonize practice improvement initiatives, because we're in a crowded space where there are a lot of entities. We just heard of several of them, example from 2 stakeholders from North Carolina, a lot of these initiatives. But the idea is, are all of these things that we're doing, are they being coordinated and harmonized in such a way that they can really produce measurable impact in addressing this continuing problem? Next slide. And that's it for me. Thank you again, and I look forward to the conversation.
All right, thanks, Steve. So I really appreciate the comments from the panelists. We've heard about state mandated programs. We've talked over the last couple of days about some of the state of of current educational programs across the board. But the question we really want to focus on for the rest of this day is really to explore what would would a federally mandated prescription education program contribute, or how it might look, and whether it should be considered for those who are making these decisions at FDA. And so I'd like to start with asking all of our panelists, how might a federally mandated prescription education via REMS benefit via REMS benefit both patients and prescribers. And I promise I'll get to the next part where we talk about the potential burdens and the challenges. But just right off the bat, do you see a potential value in a federally mandated program? So how about we start first with Elise?
Sure. So I'll say, broadly, I think something you heard from across the board is that we all agree on the value of education, right? I think we've all seen a variety of benefits from, making sure that folks have the appropriate information, not only about, judicious prescribing of opioids, but really getting serious about what it means to treat pain appropriately. And I would love to see a larger investment specifically in pain management. So, I think when we think about potential benefits, that's something. And, we do still see, even just below the aberrant prescribers that I spoke about in a talk, there is still, prescribers in North Carolina who will call not quite aberrant, but high prescribers. So I'd say, there are benefits to the education broadly. I think you heard from a lot of our panelists about that there is a lot of education out there. So, I think we have to ask ourselves about what's the marginal additional benefit compared to what else is already out there. But I think I'll start there.
Great opening remarks. All right, Bobby.
Yeah, I mean, I guess for those few states that may not require it or have a requirement that's below the level that gets physicians' knowledge up to the level that they need to sort of deal with this, that's where maybe this can fill in that gap. But that's such a small gap. And I guess I'll hold off on the comments about what the downside is until the next one. But I think that what we're trying to address is such a small segment of the physician population or provider population that's not getting it elsewhere, that maybe that gap would be filled by this solution, but it's a small gap.
Great, thank you. Anu?
Yeah, thank you. So I really think when we think about federally mandated prescriber education, we need to first consider how any new mandate would actually add additional value. I think a lot of the existing, which we've said several times now that there's plenty of existing prescriber education out there regarding opioids. I think they do a good job of covering the basics of responsible opioid prescribing. But I think, as mentioned, in terms of gaps, filling in gaps, perhaps education has the benefit of addressing issues that maybe previous requirements have not addressed. So things like, maybe identifying patients with opioid or substance use disorders and being able to recognize signs and when this is suspected and referring them to treatment, perhaps incorporating some education on MAT for OUD and substance use disorders, especially in office-based settings, because a lot of these patients can be managed in an office-based setting. Another thing that's important, which Elise mentioned, I think, is pain management, and also addressing, I would say, non-compliance or use of non-prescribed substances in chronic pain patients. So maybe perhaps addressing some alternatives to a zero tolerance policy within offices where they discharge patients automatically.
Excellent, thank you. Steve?
Yeah. So, yesterday we had a kind of a rich conversation about the nature of mandates and the nature of our health professional learners as professionals of high educational attainment who crave learning and care about improvement. And we talked about how mandated education can be a disincentive for them, particularly if it does not or fails to meet the relevance principle, which is one of the core principles of adult learning theory, andragogy, which is that if I can't see why spending these 2 hours, these 3 hours, these 20 hours is going to be relevant to the problems that I'm seeing in my own practice, that's a turnoff, and therefore it's not in anyone's benefit to do that. I think Graham mentioned yesterday that when mandatory education is around process or around competencies, or around privileges, that sort of shifts that relevance, because then it's sort of a means to an end. I think one of the opportunities that we have is maybe to focus on the how more than the what. And what I mean by that is that the engagements, to mandate engagement in interprofessionally focused, system environment aware, specific to one's own educational needs in an individualized way. To require that, I think, is very beneficial. But that's very different than saying everyone must do this, 3 hours on this topic. Because just frankly, from the conversation we've been having, that just does not match up with the very complex web of educational needs that are practice and population specific for our healthcare providers.
All right. And so, and you kind of, you start, I'm going to keep with you as we go into the next question, but, if you're saying that the main concern, whether this is relevant and for adult learners, what other concerns, or maybe that's the one that you want to dive a little deeper into, what are the burden that you think it might place on prescribers and providers, health systems, and ultimately patients, and or potentially access for that concerns that it might cause for patients?
You want me to answer first?
I want you to answer all of it.
Okay, so I hope I don't lose you in this metaphor, but and we have to be careful here. Okay, UPS. Everybody knows the brown trucks, right? So many years ago, UPS realized something that I think Amazon knows very well now, but that UPS drivers and UPS trucks were everywhere. And that, like, if you needed your cell phone fixed, that instead of UPS shipping that cell phone all the way back to the, to the company that makes it, that UPS could provide some of that service to actually fix the cell phone. That's one of the things that UPS does. In the same way, we have a national system of educational providers that reside in healthcare institutions, every medical school in the country, a lot of health systems and community hospitals, a lot of, like, all of our specialty organizations and associations, the federal government. There are educators everywhere you look. The degree to which mandates can activate those educators to allow them in a way that UPS is able to do, to say, instead of doing one thing for the whole country, they can do a million things everywhere they are, specific to the specific and unique needs of their populations, the problems, the system issues. And what's an interesting little insight here is that we're talking about opioids as if it's the only problem. It's not, right? We have hypertension and lots of other issues. So the people locally who are also looking to their physicians and teams to solve those problems also need to learn and improve. So trying to integrate these things together so that continuous improvement can be a culture of learning and reflection, and is a really important thing to sort of activate with regulation, as opposed to obfuscate with regulation.
Great, thank you. All right, Bobby, would you like to add your comments about the potential burden that such a mandate might cause?
Sure, thanks, Marianne. I guess I would echo some of the sentiment that this is a very sort of generic, non-specialty, non-situational specific solution to something that needs that specific solution. Again, as I mentioned in my comments, if I'm doing a total laryngectomy on a patient, and that's what I do all day long, every day, then that's a very different sort of patient with pain and the pain control needs than if I was an otologist doing micro ear surgery. And that's just within one specialty. I share an office with my wife, Nita, who's an OBGYN. the knowledge that she needs to sort of help her patient pain control when she's doing hysterectomies is very different than on my side of the office. So again, a generic solution to a very specific problem. And the other concern is that this is very proximally related time-wise to when the patient needs their medication, right? When they're going to the pharmacy to pick up the prescription for their pain control, and then the pharmacist punches it in and realizes that the physician that wrote that prescription hasn't done the REMS, and then the patient gets denied, and they now are 2 hours out from a painful procedure waiting to get that medication, then what, right? This is the closest, sort of REMS and requirement to patient care that we have. It's much better to require, to have the CME available, but not in a way where it could negatively affect patient care. And we haven't even started the conversation. I haven't heard much about the health equity component of this, right? Like, so for example, in Flint, Michigan, the city is a predominantly African-American population, high rate of sickle cell anemia, very poor control of pain in that specific population. A solution like this has a way to exacerbate problems in a way that we're not anticipating when there's already a disparity in access to pain care and appropriate pain care in certain populations. So just some examples of where this can go awry.
Thank you. Appreciate that. Anu, I'd love to hear from you as someone who's kind of overseen a mandate and understands the complexities there, and then hearing about the concerns that very specifically have to do with patient access and health equity. Do you see the same kind of application if it was done on a larger scale, on a federal scale? And then maybe how have you addressed some of those concerns at a statewide level?
Yeah, so, I agree, like I mentioned during my comments, my background is physical medicine and rehab, and I manage chronic pain. So I do recognize that there's a difference, for example, from the kind of patient I might see on an everyday basis versus, let's say, a dermatologist or an ENT surgeon who might treat pain more acutely after, a procedure. And to that effect, I'll say that I guess one of my concerns, or one of the things that I feel could potentially, adversely affect providers, health systems, patients, is what I mentioned during my opening comments, which is that providers have responded to increased scrutiny and this burden by reducing or eliminating opioid prescribing from their practices. So I can only, I'll speak from the North Carolina climate, which is that, there are not a lot of pain management doctors in the state. And of the pain management doctors that we have, a lot of them will not do chronic medication management with opioids. They are very interventional in terms of their approach. So they might do a lot of injections and actual procedure-based interventions for the management of chronic pain, which is totally fine. But there are, that population of patients that would continue to need chronic opioids, perhaps indefinitely. So certainly enforcing additional mandates could create access problems for patients by potentially contributing the shift towards illicit opioid drugs and other illicit drugs to replace prescribed opioids. So that is certainly something to consider that a federal mandate could potentially exacerbate.
Okay. Thank you very much. Elise?
I mean, I agree with all of my fellow panelists. I think Anu put it so nicely there when thinking about, what are not just the marginal benefit, but what are the unintended harms of this policy. I know we also have to think very carefully about provider burnout, right? Particularly as we come out of this COVID-19 crisis, right? What is our marginal benefit that we're getting versus, even any amount of extra new requirements is still a new requirement. And is it worth what we're getting out of it? I know I spoke a lot about what the state of the epidemic is now. And, given that overwhelmingly what is driving overdoses in North Carolina across the country are illicit drug use, multi-combinational drug use, right? I really think we do need to get back to treating addiction, right? Making sure that we have appropriate services there. And so I would be much more interested in educational efforts that focused on helping providers either refer to or provide themselves office-based addiction treatment, rather than sort of, using this very broad tool to sort of, broadly target opioid prescribers. I think Bobby also put this extremely well. And I also want to reiterate, I'm sure I'm going to sound like a broken record writing on this with PDMPs, but being here at the state, it's such a powerful tool, right? Who our high prescribers aren't a mystery, right? We know who the high prescribers are. We have that data. And so why make every single prescriber do this new requirement when we have the data right there? The federals have it, every single state has it. They can log in and say, okay, this is, here's what aberrant prescribing is, here's where we think, we may see something truly almost criminal. But then there's, that next 1% of high prescribers, and you can look into the data and say, okay, well, this is a high prescriber, but they're in palliative care. And so makes sense. This person is in a high prescriber and, their specialty doesn't really seem to explain it. And so maybe this is worth a further conversation, right? In the age of such huge data, I just think it's our responsibility to use the data we have at our fingertips to make our interventions as effective as possible.
Excellent. Thank you so much. So kind of staying with the idea about treating addiction, we have this next question about, what would be appropriate program goals. And I've heard, having a larger shift onto addiction rather than just on opioid prescribing practices. Also heard from Steve about how it's more so about being a way to enact the already many programs that are in place instead of creating something that is one appropriate, like one program goal across the board. I did just want to ask before opening it up to discussion. You mentioned at the onset, Bobby, that you have a kind of a partnership with the DEA. How is that, meant to, is it reducing stigma? Is there an educational component? Are there something that we could learn there that would be something to consider as an appropriate program goal as we're thinking about these programs more largely?
Yeah, absolutely. So it gets to the point of proper provider education in a way that's useful to sort of address this issue. That's exactly what we're doing at the DEA. And again, we would love to sort of engage in that dialogue with the FDA. But again, it is exactly about that. It is raising the level of knowledge in a way that is useful to our practice, that we would love to collaborate with anybody and everybody on this issue. DEA, FDA, state societies. There's so much great work. We just heard again about the great work that North Carolina is doing in pioneering the role of education in a way that is as specific as possible, as close to my daily workflow as possible to make it relevant. And that's, and I think that's where we are going to improve this.
Great, thank you. And Steve, do you have anything else to add to if, what an appropriate program goal might be if we had a mandatory prescriber, if we could think of a way to make it into the kind of enabler of new types of programs that are more tailored, or what in your mind is an appropriate program goal for something at the scale?
Yeah, I think Elise provided the answer, and that PDMP suggestion again. We have to be cautious not to create sort of like a one size fits all, but this idea that at a national level, at a state level, at an institutional level, we have a lot of data, creating opportunities for data and educators and quality improvement, like those sorts of stakeholders to work collaboratively, whether it's a small office or it's a health system, is a way to create kind of what we call in andragogy and in adult learning, the building the readiness to learn. When I see what my behavior or what my practice is in comparison to other clinicians in my system, and not with a punitive letter, but with a coaching, announcement, and maybe a meeting or something where I can work in partnership with educators or with other clinicians or with my team, to improve that, that really shifts this into what we know in education to be a much more effective way to create change. Another part of this, which doesn't directly answer your question, but I wanted to say this, is that in terms of educational outcomes and impact, I don't think we're doing enough to lean on educators as opposed to trying to do some sort of a central analysis. We should be looking to educators to use the tools that they already have as accredited organizations to measure the outcomes, the impact on behavior change, on patient outcomes in collaboration with their institutional partners and quality improvement and elsewhere, in collaboration with licensing boards and PDMP and law enforcement, all the different ways that they can look at data and how their education might have an impact. And we should also encourage them, as we do, to publish research about the effectiveness of their educational approaches, so that Elise can publish the work that they're doing in North Carolina, so the rest of us can learn from what Elise is doing and figure out how to get right.
Excellent. Thank you. Anu, did you have any other additional comments to kind of an overarching program goal?
No, I mean, I'll just reiterate what I just said, as if we're thinking about program goals for any type of mandate. I think we need to consider how it would actually add value over what is already in place currently. We've talked at length about how there is a plethora of CME on opioid prescribing, and also how, prescriber education mandates are fairly common, like we discussed today and like they've discussed yesterday. So I think if we were going to identify any goals, it would be really one, to see how they add value, and to identify current gaps, which we've addressed. For example, I've mentioned, identification of OUD or substance use disorders, identifying treatment options and getting patients to the right level of care and the right treatment, practical information on introducing office-based MAT in a primary setting, for example. I think some of this can be managed by a primary care physician. I just mentioned the lack of, in general, pain management providers across the state. There's also somewhat shortage within our state of MAT providers, and a lot of the providers that are Data 2000 waivered may not be able to practice at full capacity in terms of seeing these patients. So there's a multitude of issues that can certainly be incorporated into education. I also mentioned non-compliant patient behavior. So those are certainly things that can be woven into education.
Excellent. Thank you. I did just want to continue this thread. If you were joining us yesterday and heard the presentation from some of the colleagues at FDA talking about if, as they're trying to look forward and think through the complexities of what a mandate, a federal mandate might look like, just the potential that this could be a rather large program, especially in comparison to the largest programs that they have to date. And obviously that would have a number of logistical considerations. And so a few of you have mentioned data and how, Elise, you say, your providers, who's the high prescriber, how to reach them, that information can be shared, you can access that. As we think about something that would have to be scaled at a larger space, what would you give as guidance for the data considerations that would have to go into place if we were to look at this from a federally mandated approach?
Is that two?
I'll give this to you, Elise. Yes.
Okay. So I'd say, what are the considerations, right? And this is actually something I have to give credit to Anu for when she and I were talking on the side, is really, so maybe she'll pipe on and talk a little bit more about it, but really being thoughtful about what data infrastructure exists and what we would need to build, right? And so, I think a huge lesson that North Carolina Department of Health and Human Services learned during the COVID-19 pandemic, and our response to that, is we basically had to build an entirely new data infrastructure system from scratch. And that is in and of itself no joke, right? And so I'd say, I think key considerations are, what are the data we already have? Because I think, as I said before, I think we have a real responsibility to providers to use whatever data we do already have to try and reduce the burden and make things as efficient as possible. But then I'll kick it to the other experts to really talk about asking questions like, what would building a new data infrastructure entail?
Yeah. Anyone want to take that one on?
I can speak to, I think that there's an interface between regulatory federal and state data infrastructures, and then on the flip side, sort of an infrastructure around educational engagement. We have been working steadily to build data systems that house information about educational activities, what educational needs, gaps they are addressing, how they are being measured, evaluated for, designed and evaluated for changing the strategies, performance, and patient outcomes for the learners and their patients. And I think that, going back to the National Academy of Medicine publication that we're about to publish, some of our key priorities have to do with aligning some of those data systems so that, for example, if regulators were able to reveal to clinicians where their gaps are, that they could then in turn come to the continuing education system and say, I need help addressing this practice-based problem, and find educational activities or educational providers, coaches that could help them to do that. So that's my contribution.
Excellent. Anyone else before I move on?
Yeah, and this is Bobby. Just, I guess when yesterday, the most alarming moment in my mind was when we were talking about extrapolating from a REMS program that affected 100,000 people to one that now affects 1 million physicians, right at the moment where their patients are going to get their prescription filled, and all the potential pitfalls of that sort of left a pit in my stomach about what patients will go through if that rollout, the first of its kind, size-wise for a program like this from this group, doesn't go well.
Fair point. Anu, did you have a final comment on this?
Sure. No, I was just going to comment. I apologize if I might have to turn off my video just in case. I got this notification that my internet connection is unstable, which is never a good sign. So I'll try to be brief. I was going to just comment and say that I think, any federal mandate would likely not be welcomed by prescribers, no matter how well it's designed. So just to keep that in mind, that the FDA would likely face some pushback from prescribers and medical specialty societies. I'd also add, in terms of logistics, in terms of enforcing these type of requirements, would that fall to the medical board? It would fall to the DEA. So that would be a little bit of a logistical challenge. And then also compliance we talked about the occasional prescriber. So somebody who doesn't manage chronic pain and maybe writes a prescription very rarely, how would they factor into this? Just in terms of developing the actual CME content, that's a bit of a challenge as well, and making sure that the educational requirements stay in line with the current issues of prescribing. Thank you.
Great points. Thank you. I think for my last question, and it might not necessarily be about just the mandatory program, but we've talked a lot about that gap, that group of providers that at least very, very well may know who they are, but we know that they have high prescribing practices. And, even when there's the option of additional education, we're not seeing a change in behavior. And Bobby was saying that it might be some states where they don't have a federally mandated. So there might be those they might not have access to the education, or even for the states that they do have access, it's not making those changes. Do you have any lessons learned about how you think we can impact kind of those prescribing behaviors in a way that as kind of a last word you would like to make sure that we think about as we're thinking about just kind of the next phase or the next level of really how to reach that particular gap? Steve?
I think that we have to acknowledge the complexity here and the idea that what we know from the educational literature and is that continuing education is effective in doing what it is designed to do. So when you have education which is thoughtfully designed to change behavior and patient outcomes, it does so, but it does so in a intentional way, in a way which is interprofessional and multimodal, and longitudinal over several interventions, and not generally over, a 2-hour webinar. So when we say that it's not effective, I think we have to kind of broaden our perspective to say what kind of latitude and what kind of engagement are we allowing education providers to have with these clinicians and teams to sort of solve the problems that they have. Blake Fagan yesterday did a terrific job, and there was another speaker who also gave kind of a couple case examples to show just how complicated it is to be effective in implicating the things that we're trying to teach. And we are never going to achieve that with a one-size-fits-all program. We really need to put power in the hands of educators and other stakeholders like Elisa's group to be able to work collaboratively to solve these problems for folks.
Thank you. Elise, you set you right up. Final remarks?
Sure. So, as we prepared for this conversation together, I spent a lot of time thinking about, and this is just something that is also in the nature of my job with opioid response, a lot about the interventions that I see now that I wish I had had 15 years ago. That I think about, man, if we had this going 10 years ago, 15 years ago, what could we have avoided? And so I think it's really worth thinking about, we have a lot of lessons learned. I like to say, responding to the opioid epidemic is not new news to us anymore, right? We have a lot of experience doing it. We know what works. And so I think it's really worth digging into our data, looking at where we are with the drug supply, with addiction science, with how mature providers in general have gotten in this space, and thinking about what are the interventions that we're going to wish we had 15 years from now, right? Where do we need to be down the road, and how can we start now in getting there? And so whether that's things like mass education on buprenorphine prescribing, really tackling meth and cocaine and benzodiazepine use in a more serious way, even thinking about things like education around harm reduction approaches, I think is something that we could all really benefit from. And so can we be the thing that whoever has my job 15 years from now sort of says, oh my gosh, I'm so glad we had X, Y, and Z thing. That's my closing thought as I think about this.
That's a great closing thought. Bobby?
Yeah, when you mentioned sort of the outliers, right? People that I get identified, we shouldn't automatically make the assumption that they are not practicing properly, right? We have a lot of physicians that are internal medicine trained in my own community that also do nursing home care, palliative care. And so if you look at their PDMP data, they'll be outliers, right? One of our own past presidents of the American Medical Association, the T-Monk, was labeled as an outlier. So we shouldn't automatically think that they need remediation just because of their outlier status. As Steve was mentioning, there are specific practice things that need to be looked into to first confirm, okay, is there something about their practice that is having them prescribe some X more than the average before automatically assuming that they need some remediation or education.
Excellent. All right, Anil, final remarks. All right, I think we might have lost her from her unstable internet.
I'm here.
Oh, there she is.
I froze up for literally a second, so I'm gonna talk quickly. No, I was just gonna say I appreciate everybody's comments, and they resonate well with me personally as a physician who sees these kind of patients, as well as a member of the medical board. I'll just additionally add that, licensing bodies such as the medical board and FSMB, we are not there to sort of be gotchas to licensees and to say, okay, well, we're just waiting for the moment that we can take away your license. We really want to serve as a source of information, and we want to see our licensees' success and practice at the top of their licenses. So, I appreciate being able to have these conversations with a wide variety of stakeholders, and I think it's a very timely and important conversation. I think it's important.
All right. She thinks this
Look
is
at
important. Oh, there we go.
Yes, I'm sorry. No, I apologize. I'm going to go off video for just a second. I was going to say that I just think it's important for us to keep up.
All right, we know what the sentiment is there. I think we've heard such great things from Anu, and really appreciate her comments. And she feel free to finalize any comments that you might have in the chat, Anu. So I just want to say a brief thank you. This has been an excellent panel. Really appreciate this discussion and kind of the range of ideas and your willingness to put out some different thoughts and about how FDA could approach this, but also how different states and clinical societies and other educators are really trying to address the many complex issues around opioids and substance abuse that we're facing. So thank you to all of the panelists. And with that, we're going to take a short break. We will return at 2:45 Eastern time for our final panel of the day. After the break, Dr. Mark McClellan will be joining us to facilitate the panel on next steps. Thank you very much.
Good afternoon or good morning, depending on where you are. Welcome back, everyone. I'm now very pleased to move on to our final panel of this packed event, where we're going to be discussing next steps for opioid prescriber education, and particularly the opioid analgesic REMS, based on and building on a lot of the discussions that we've had already. And just these came up in the last session, but throughout the last couple of days, just like to emphasize that we've heard about a range of issues related to prescribers, making sure that we're identifying and addressing gaps in educational needs that reflect providers' daily practice, setting patient populations, and other special and specific issues for particular kinds of prescribers. We've heard a lot of perspectives from patients. Patients are and are going to continue to face acute access issues from current state health system, other mandates, and want to make sure that patients are getting effective pain management, effective management of OUD and substance use disorder. So how can education programs facilitate getting the most effective care to patients as safely as possible. And then we've also heard a lot about logistics issues, balancing, say, the scalability and relevance of a mandatory educational effort like utilization of the PDMP, but a need to tailor to these individual specific needs and settings. So very much looking forward to our last panel for our panelists to have a chance to discuss these issues. And again, we've had a lively discussion going on with the Q&A and chat. So I encourage everyone to submit questions and comments via Q&A during this last session. We'll try to incorporate as many as possible. For this session, I'm now pleased to introduce our diverse panelists. First, Stefan Kertész, who's professor of medicine at the University of Alabama at Birmingham and an attending physician at the Birmingham, Alabama VA healthcare system. Kate Nicholson, president and founder of the National Pain Advocacy Center. Daniel Pace, chief strategy officer and vice president for education and outreach at the American Academy of PAs. Friedhelm Sandbrink, who's National Program Director for Pain Management, Opioid Safety, and Prescription Drug Monitoring Programs in the Veterans Health Administration, and David Tobin, who's Emeritus Clinical Professor in the Departments of Medicine and Anesthesia and Pain Medicine at the University of Washington. I want to thank all of our panelists for joining today. As in the previous session, we're going to start off with about 7 minutes of opening remarks from each on pulling together these issues, and then we're going to have some time for discussion. So Stefan, let's start with you.
Great. Let's make sure you can hear me.
That's just fine.
Great. Okay. So like Dr. Krebs yesterday, I need to say straight up, I'll be sharing my own opinions and not those of my federal employer. I want everyone to know I happily serve on the Volunteer Scientific Board for the National Pain Advocacy Center. And as for disclosures, I own shares in 2 biomedical equipment companies, Zimmer and Thermo Fisher, and I briefly owned some CVS Caremark in 2020, but I had it sold as soon as I learned my broker had purchased it. While you absorb this very blunt title, I want to make one thing clear. I really support education on pain, on opioids, on addiction, on disability, and I love participating in it. But the title is kind of the case I'm going to make. So next slide. I think to speak about what REMS is good at, I think it's good to talk about a solid model for one, which is a national mandatory REMS, the prototype really, which is the one we have for isotretinoin or Accutane. I think even I had to pledge when I got Accutane that I would help prevent pregnancy-related exposure. And the model for this is very straightforward. Just tap once and animates in on. Yeah. So there's a specific disease condition. It's one we all learned about at least a bit in medical school. There's a disease-specific treatment that really works for it. There is a specific concrete risk to the drug attached to its pharmacological properties, and there's a REMS to mitigate that. So now let's try to apply this onto pain, and I'm going to be thinking more prototypically with chronic pain. Tap, please. So there's the same effort to map it onto pain, but if you tap once, you'll see the first challenge. So for the individual with pain, particularly if it's long-term pain, it's not exactly a single disease like acne, like we all learned about in medical school. It's whatever the patient's pain condition is, and the plan of care are very much wrapped in all of the elements of the psychosocial model, which are shown in green bubbles. And in the context of the patient's life, whether they have addiction or just dependence, in potential trauma our patients have already experienced in the health system and in disability. And one of the biggest problems here is that, we're talking about a REMS for a condition we weren't taught about very much in medical school, which is just a very different situation. The discussion can get so myopic, and particularly just about the opioids, when there's a condition in the background that we actually need to understand in a much fuller way. Tap once, and then there is a treatment. I understand there's debate about the efficacy of opioids for chronic pain, but it's in a web of other treatments that also potentially apply to the same patient. We're not just choosing one thing and mitigating its risk. We're trying to adjust course amongst all of these things, each of which has some debate about its efficacy, accessibility, et cetera. And then we get to the risk of the prescription. Tap, please. The risk is not solely due to the pharmacologic properties of the drug. Such data as we have on overdose, at least, and here I put in a citation from Elizabeth Oliva in the VA, where we use a risk mitigation model called STORM. The risk data that we have suggests that opioid-related overdose risk is influenced heavily by many other factors that are going to influence the volatility of the patient's pain, the volatility of their relationship to our clinic, and the reactivity of the prescriber at times. And so things like depression, PTSD, prior mental health diagnoses, whether there are co-prescribed substances, whether there are coexisting medical conditions, are all influencing the actual risk equation. Dose is relevant in there, and yet it's only one among many factors. Tap once more. The prescribing decision sits for the clinician amongst what I have outlined in orange traffic cone color, a set of other concerns and realities, social influences, collective reckoning with an overdose crisis that we contributed to, real scientific disputes on what opioids can deliver. I won't list the contents of all the boxes, but I really want to draw attention to the reality that one of the contextual elements we prescribers negotiate is that we know there's no actual safety monitoring or ethical account of any kind for the patients we cut off. That is, there's a lot of concern about what we prescribe, but if we cut someone off that's not tracked systematically in our healthcare systems, there is no payer mandate to follow up what happens to those patients. So we're in a sort of odd ethical space as we're making these decisions. And therefore, tap once, please. I wind up really unclear as to whether REMS expansion about opioid prescriptions really addresses the web of the patient problems, the set of alternate treatments we need to consider, the actual risk, which is not just pharmacologic, and the environmental factors that determine our decisions. With that, I want to turn, next slide. Obviously reducing of prescribing has happened, and we understand that overdoses did not decline. Next, just tap once. And I understand that we could argue that maybe overdoses involving potentially prescribed overdoses did decline if you look at some numbers, and the synthetics contributed to the overdoses. There's a big debate to have about that. I'm not here to adjudicate it, but the one goal that our prescribing reduction did advance is shown on the next slide. The biggest concern was we want to reduce the likelihood that persons in emerging adulthood who are at the highest risk of developing new onset addiction would not have such easy exposure to these drugs, much as you would read about in Beth Macy's book, Dope Sick, where new onset addiction was so easy to do. And this is monitoring the future data. They have a 19 to 30-year-old bracket panel. The Vicodin question began in 2002. The narcotics other than heroin question goes back to 1988. Today's numbers of past year misuse in those two categories are the lowest they've ever been on record. They're lower than they were in 1988. So I think we could say that one goal that we attempted to achieve was advanced successfully by this reduction. So I'll offer some conclusions at this point. Next slide. We have an enduring prescription reduction, a massive prescription reduction. It contributed to the reduction in young adult use. That is very substantial. These reductions are highly incentivized. As the FDA has noted, they're often abrupt and unsafe. Patients with chronic pain often do wind up without someone to care for them, an issue my friend Kate Nicholson will talk about next. I really think looking forward, we should ask about the first part of that original graphic, those conditions that contribute to the condition and the manifestations and the care of pain, whether that's the pain, original tissue injury, the psychological constitution of the patient, the trauma our healthcare system has befallen, that is imposed upon our own patients. These are the things that most crucially should be trained in health profession schools and then reinforced or mitigated to the extent that we failed to train it in continuing education. It stuns me that there is no or very few accreditation requirements related to any of these topics for medical schools or residency programs when we've been in this crisis for a decade. It should seem to me you can't be an internal medicine program with credentialing unless you're doing a number of things in these domains, from buprenorphine prescribing to other things. I don't think mandatory REMS fit the problem as I've laid it out, and I do worry they may incentivize abandonment or even trauma at the pharmacy counter. People interested in other presentations of my views can check out my TEDx talk or the addiction publication listed. Thank you so much.
Daniel, thank you for the thoughtful comments. Also, thank you for introducing Kate Nicholson. Kate, you're up next.
Thank you. Hi, everyone. My name is, if you tap one more time, it'll continue on the slide. There we go. My name is Kate Nicholson. I am the president of the National Pain Advocacy Center, which is a new nonprofit that takes no industry funding and advocates for people with pain. We're a group of scientists, clinicians, civil rights and health policy experts, and people with lived experience. Among our people with lived experience are those with serious conditions causing pain, as well as people in recovery from an opioid use disorder. So this is a topic that's very important to us. Next slide, please. As Stefan mentioned, I am going to talk a little bit about one consequence of a pendulum swing in the philosophy on opioid prescribing, and that is pressures on prescribers and the patients they treat. So you'll see on the right hand of this slide is a headline that says pain patients who take opioids can't get in the door at half of primary care clinics in the United States. And that's based on a study that was done in clinics in 9 states that found that providers would not take on a prospective patient who used opioids to manage pain. Another study done by Quest Diagnostics and the Center for Addiction found that 81% of providers are reluctant to. So these are pretty big numbers, 81%, 50%, and are not willing to treat or are reluctant to treat patients who the healthcare system itself put on prescribed opioids. And many of these people have taken opioids for a long period of time. It is difficult to know, given the drops we've seen in prescribing, exactly how many people take opioids long-term, but based on recent studies, it's safe to say that this stands to affect many millions of people. It is, incidentally, a violation of the Americans with Disabilities Act to refuse to treat someone based on the medication they take or their medical condition, but providers seem to be more responsive to other pressures, whether that be DEA oversight, state medical boards, local healthcare systems, et cetera. Next slide, please. This is a problem that is increasingly becoming recognized. On the right side of this slide, you see a letter from the California Department of Public Health that was issued last month. And it talks about what it describes as a common problem in which many patients with long-term opioid use find themselves suddenly stranded and without a doctor. Next slide, please. I also want to address a little bit of concern about the content of training. One of the things that we've seen in an environment where there's a lot of oversight and there's no clear legal definition of an overprescriber or of overprescribing, and an environment in which the usual course of the profession is changing, is in flux on the topic of opioid prescribing, is a lot of fear and uncertainty, as well as the use of proxies for appropriate care. And one of those proxies is morphine milligram equivalents, or MMEs. We know that from evidence that increased doses can certainly increase risk, but what we're also seeing is that thresholds, specific MME thresholds, are being used to flag providers and to flag patients, and that this has been correlated with abrupt and involuntary tapering. So at the end of 2018, Human Rights Watch issued a big report in which it found that patients were being taken off their opioid pain medication or tapered down, often against the best medical judgment of providers who were doing it because of fear of outside pressures. We also know now there are more than a dozen studies showing how tapering is happening in practice. First, that it often happens abruptly. There are now a number of studies showing that it may actually increase the risk of death to a person who's being tapered, in addition to destabilizing their health, their mental health, and their lives. And it's associated with termination of care relationships. Now, obviously, the concern here is about abrupt or indiscriminate tapering and about how and why it's happening. Dr. Krebs presented yesterday about appropriate tapering, which certainly helps some patients, but there is a concern that patients are being sort of lost and their well-being is being lost in this conversation. Next slide, please. So I know we're going to delve into this a little more in the discussion, but the question is whether mandating training through the REMS program on opioid prescribing will be a benefit to patients and providers or an additional burden. The first question is it responsive to the current environment? Well, I would argue that more targeted focus on polypharmacy use, harm reduction, a safer street supply, and expanded treatment for addiction would probably be more responsive based on everything we've heard over the last couple of days. I also agree with some of the conversation yesterday, suggesting that pain management is much bigger than a single modality, that managing the pain of 50 million Americans with daily pain and nearly 20 million with disabling pain requires, better, broader education, better access to a host of modalities, of which medication is one, but only one. But also it's important to recognize that addiction is broader as well. couple million people have an opioid use disorder related to prescribed or illicit opioids, but nearly 20 million have a substance use disorder of another sort. So it's important also to target both of these issues more broadly. And the question is whether one more course just focused on a single modality is going to do a lot of good. Is it measurable? Well, the FDA has said that it's difficult to measure the effect of training because of confounding factors. And one other thing that Stefan mentioned that I'd also like to mention on the measurement question is that the measure that we seem to be looking at all the time is reduction in gross opioid prescribing, but we don't have any metrics to follow patient outcomes. And that is problematic. Does it overlap with other efforts? According to the FDA's materials, 98% of the population lives in states that already have requirements for training on opioid prescribing or pain management. And finally, what may be the unintended consequences? My grave concern is that one more mandate in an environment that has already got a lot of oversight may just further drive providers from engaging in medication management, treating patients, and may impede access to care for a very vulnerable group of patients. Thanks.
Great. Thank you very much for those comments, Kate. And next up is Daniel Pace.
Thank you, Mark. So thank you, everyone. It's a privilege to be here with such an esteemed panel. I can tell you I've already learned quite a bit throughout the workshop. My name is Daniel Pace. I'm the Chief Strategy Officer at the American Academy of PAs. I also oversee our research and education teams at AAPA, and hoping to bring a few areas of perspective to the conversation today. Specifically in my role at AAPA, I oversee our CME accreditation services, as well as our credit system. So have sort of experience with the existing REMS by way of the accreditation lens. But we also at AAPA are a CME provider. In addition to representing and advocating PAs, we of course also strive to educate PAs, over 150,000 across all medical and surgical specialties. And that, of course, includes sort of a continuum of efforts, starting with continuous assessment, trying to identify practice gaps and unique educational needs across specialties and settings, planning meaningful educational interventions and delivering those interventions, and hopefully effectively assessing outcomes using what we learn to complete that cycle, which again you saw Steve so elegantly share earlier, to evolve our learning interventions and continually have an impact on practice. With respect to the topic at hand today, I in my career at AAPA, I've had the experience probably about 10 years ago of sitting down with a group of accreditors that were discussing with FDA sort of, not too different from the discussion we're having now around sort of what would the design of an effective REMS program look like for the ERLA class of opioids. And at the time, similar to what you've heard from many of the education-related stakeholders throughout this workshop, we all believe that education has an important role to play in improving outcomes. That said, the implementation and some of the standardization along the way presented challenges that made it difficult to really harness the power that continuing education and that continuing professional development as sort of a whole can provide in addressing this epidemic. AAPA, of course, is also a CME provider, so we not only had sort of a perspective from the accreditor side, but had experience trying to develop and implement and recruit learners for REMS compliant programming for the better part of the last decade. And I've experienced some of the challenges both with participant feedback from those sessions, as well as regarding relevance of the content, as well as sort of limitations and what we were sort of empowered to measure in terms of the outcomes, beyond just whether or not individuals learners were participating in the activity. I'll say also, you heard a little bit earlier today from Steve and yesterday from Kathy about the National Academy of Medicine's Action Collaborative. I'm lucky enough to participate in the Education and Training Working Group there. And it's probably apropos that I didn't produce slides today because frankly, they would have looked a lot like some of the slides that you saw from Steve earlier today. So some just kind of opening comments. I'll say AAPA is of course supportive of efforts to expand educational opportunities for prescribers. We're strong believers that continuing education can be an impactful tool to improve outcomes, but only if certain conditions are considered. First and foremost, the activities need to be designed to close practice gaps. They need to be targeted and tailored to clinicians' unique needs and preferences. I've had some great examples of that from some of the panelists in the last presentation. A point that Steve hammered home quite well is that the education needs to be consistent with adult learning theory and andragogy. So specifically, self-direction, that individual learners need to take the initiative to engage in their own learning. They need to be motivated by the relevance of the learning and the content, and they need to see the value and purpose to really yield benefits from their participation. And it needs to reflect the experiences that they have had in their practice and problems that problems and challenges that they're facing every day. Finally, the education, of course, needs to not present an undue burden. And there's already been some good commentary around how additional requirements, could be seen as a burden, contribute to burnout, even if they are not necessarily perceived as overburdensome when considered in isolation. When you consider them in the context of, all of the educational requirements and other systems-based requirements that clinicians face these days, layering one small requirement on top could be, the straw that breaks the camel's back, proverbially. So a mandatory requirement from our perspective has the potential to, result in clinicians engaging in the learning, yes, but unfortunately, probably doing more of just checking the box. I think we've seen some of this with some of the state requirements that are in place now. And ultimately, this has the unintended consequence of limiting the effectiveness of those educational interventions. Already have been good discussion around the potential to contribute to clinician burnout. And of course, good commentary so far and the potential to deter some clinicians from prescribing opioids and providing effective pain care and limiting access to care. I think another lesson learned from the existing REMS program is kind of the unintended consequences of standardizing training, which I think on the surface may be seen as one way to one benefit of potentially a national requirement, but unfortunately the standardization has the potential to limit the tool set of CE providers to actually affect change. It can preclude innovation in those interventions that can be more problem-based. And I think as we've seen, throughout the last decade, and even as reflected in the recent updates to the blueprint, has the potential to preclude intervention, or has the potential to preclude or to lag behind advances in evidence and essentially where the epidemic is evolving to today. So I'll stop my comments there. I know we'll have some more good discussion, and go ahead, Mark, you take it from there.
Great. Thanks very much, Daniel. Appreciate the comments. And next is Friedhelm Sandbrink.
Hi, good afternoon or good morning. Thank you, first of all, Duke Margolis and FDA for organizing the call. This really has been a pleasure so far to being able to participate. So I'm Friedhelm Sandbrink. I'm speaking to you with my experience as a neurologist and pain physician at the Washington, D.C. VA Medical Center, who provides care in an interdisciplinary pain management center, right? So we include the whole spectrum of pain care, but also have an opioid pain care clinic that has 3 X-rated prescribers, and we prescribe buprenorphine for pain conditions and patients with pain conditions and co-concurrent OUD. But I also come and speak to you on, while I'm speaking on my behalf, I come with the perspective of the Executive Director for Pain Management, Opioid Safety, and PDMP in the Veterans Health Administration. And I want to talk a little bit about our opioid safety initiative in the VA. Like what we've heard already in regard to prescribing in the general US population, the peak prescribing of opioids in the VA was in 2012. In Q4 of fiscal year 2012, about 22% of our veterans who had a pharmacy activity in that quarter actually received an opioid medication. Since then, we've had a marked reduction. But that year, we started the Opioid Safety Initiative as a pilot in several VA facilities, and it was then expanded nationwide in 2013. And while the goal and a narrow focus would be to reduce the reliance on opioid analgesics for pain management and provide for safe and effective use of opioid therapy when clinically indicated, it really is part of a much larger comprehensive opioid stewardship program. So education is a component of that, and I will talk more about that in the second half of this brief presentation. But we've had mandated prescriber training about 40,000 clinicians since presidential mandate in 2016. But we also rely very heavy on an academic detailing model. But in addition to that, what we realized early on is that we have to provide better access to pain management options that are not pharmacologically, not procedure-based. We have a step care model for pain management, expanded greatly access to behavioral and CRH modalities. We have now a mandate for pain management teams, pain clinics at all VA facilities since 2017. In addition, we've expanded now access to addiction treatment, a step care model for opioid use disorder training that has brought buprenorphine prescribing to primary care pain clinics, general mental health clinics, where they are supported, where physicians or clinicians are supported by the appropriate specialty care for SUD at their facilities. But centered to that is really an opioid safety initiative dashboard as well, that makes the opioid use visible within the VA and provides in particular overview of the implementation of risk mitigation strategies. And those risk mitigation strategies really we provide education of that, but we also have implemented in the VA system. Just to give you a few of that, we've had informed consent mandated since 2014 for patients on long-term opioid therapy, PDMP checks, a national directive since 2016. We've provided the overdose education and naloxone distribution effort, with really have provided naloxone to over 300,000 veterans. We've had more than 2,000 reversals in regard to opioid overdoses with that. And we also do opioid risk reviews of the highest risk patients. So really these kind of policies have to support any kind of education. And with that, we've seen a marked reduction in opioid prescribing. As I told you, we had 22% in 2012. In fiscal year 21, it was now 7.8%. So that's a 62% reduction. We've also have seen a reduction of high dose opioid therapy by 78%, long-term opioid therapy by 65%, and in particular opioid and benzo co-prescribing by 88%. And much of that is also by not starting new patients on long-term opioid therapy. Just a little bit of information about education and training. So in addition to this mandated training about opioid safety that we issued in 2016, not specifically focused on the opioid medication, but really on much broader pain care and improving access to general pain care and what is evidence-based. We also have education about the CDC guideline, as well as our VA DoD clinical practice guideline that we issued in 2017. With annual training that was in person at one point, then obviously had to be virtually, about pain care with more than 1,000 providers participating each year. Pain mini residencies, lots of webinars that support. But the bottom line is, and that is what we've heard from our clinicians, is that we have to have a consistent message. If you are in primary care or pharmacy or wherever you are, you must receive a consistent message that is coordinated and aligned across program lines. And it isn't perceived as being inconsistent, whether it comes from your administrative leaders or versus your clinical leaders. We also know that in regard to overdose risk in veterans, that the role of the actual prescription and the dosage and the duration, while that is clearly linked to higher risk, is actually relatively minor compared to the risk associated with the comorbidities of the individual patient. When we look at high dose opioid prescribing, patients on more than 90 milligrams of morphine equivalent, those represent only 20% of the patients who have an overdose from opioids or had a suicide related by being on opioids. And 80% are lower. But at the same time, 4 out of 5 patients who have an overdose or suicide event, they had prescribed less than 90 milligrams of morphine equivalent. 3 out of 4, I should say, have a mental health diagnosis or substance use disorder diagnosis. And while we know that the dosage is a factor, a history of having PTSD or alcohol use disorder is just as strong as a factor as being on an opiate medication with a dosage of 120 milligrams of morphine equivalent in our own model. And we know that a depression history increases the odds ratio of an overdose death by a factor of 5, whereas an opioid and benzo prescription in our data was only 1.4. Still significant, but we have to get away from concentrating on the prescription, but truly look at the patient. We have to see this from a whole person perspective. We have to train our providers to be patient-centered care and taking in the nature of the pain condition, integrate the medical and mental health comorbidities, in addition to managing the opioid prescription itself. We already heard about opioid tapering quite a bit. I just want to say, and obviously I wholeheartedly agree with Dr. Krebs' example yesterday, the patient on chronic neck pain was successfully tapered by just going very slowly. And I want to emphasize, and while that may not be apparent everywhere, and we've had an opioid tapering guidance in the VA since 2016 that warned against abrupt discontinuations, stressed an integrated approach, the goal to improve function and long-term safety by reducing risk, but really long-term function for patients in a patient-centered way who undergo opioid dosage reduction. And I think we've heard already, and it's becoming more apparent over the years, that there is a risk associated with tapering itself. So coming back to our training, I think we have to realize that training has to be provider specific. It has to be valuable. The surgeon who sees patients who are primarily opioid naive and who may prescribe opioid medication just for the short term to treat acute pain. The goal is here probably to reduce the exposure and protect the vulnerable patients, such as adolescents, but that's very different from the patient from the provider who treats patients with chronic pain in a pain clinic setting. Possibly in conditions that should be treated with opioids at all. But we have to make sure that we have valuable training that takes those specific needs into account. In the VA system, much of what we do for training is with an academic detailing process. So that's in-person outreach, educational outreach that is evidence-based, knows about the individual prescriber's prescribing pattern. Pharmacists really skilled in persuasive communication, who form a trusted and useful relationship with the providers, so that there is non-biased information that is valuable. And so with that, I think I just want to make a few more points regarding training that has to include opioid use disorder and medication for opioid use disorder. Clearly, there's a stigma for patients on opioid medication. Access is getting harder for those. There's a stigma in patients with chronic pain, and there's obviously a particular stigma for patients with opioid use disorder and chronic pain, which is so common in this condition. Clinicians want to do the right thing. So we have to provide, it's our responsibility to provide non-biased guidance, preferentially not industry sponsored, that puts the emphasis on the patient, not on the medication, as I explained. We also realize that, as was pointed out, burnout is a reality. Training must be perceived as supporting our busy clinicians, not as a burden. So it has to be of highest value that motivates patient-centered care that is team-based and integrates across service lines.
Great. Thanks very much, Friedhelm. And your comments already generated a couple of questions. I appreciate it. Next is David Tobin.
Well, thank you. And I appreciate the privilege of participating with such esteemed colleagues, and personal thanks to the Duke Margolis Center, the work by the team that gave me the information and got me all set up. I thank them. And Dr. Mark McClellan, who's done a really good job keeping this on time and giving us great summaries. I have two dubious distinctions. One is being the final presenter of the group of whom I agree 97% with. So I'm going to be just stressing some of their points, and hopefully our discussion will be able to broaden that later. But also the emeritus category, which is dubious. I'm now not working officially, but I am working, coming here today and continuing with my activities. So let me tell you a little bit about myself. Next slide to set the context. So a couple of personal perspectives. I come 30 plus years of primary care practice in a community-based internal medicine program. When I began my training, I had exactly 0 hours of pain education as a medical student at a fine university, and learned nothing about it. So I became interested in it at UW, which is where pain medicine as a specialty really initiated, and the biopsychosocial model of a multidisciplinary pain clinic began, and had the opportunity to taste a little bit of the multidisciplinary experience as a clinician, and moved into a pain specialty certification. And I want to just note that it's not 56 years, it's overlapping a good many of those in those years of practice. One comment, I might get to it later, is I'm certified, but in a non-ABMS board, which means we had to create a subset of characteristics that permit me to be considered a pain expert, because the American Board of Anesthesia requires a certification through one of the residency training program that I had. And there were so many obstacles to proceeding. I just went ahead and took the ABPM. I'm happy to say that after it was the first year it was given, and I was asked to write questions for it the next year. So I knew what I was doing, but really struggled. And it's been a problem getting internal medicine people pain trained. Now, who's going to take who's going to do a fellowship in pain and understand the primary care perspective? You can get it at family medicine level, but as an internist specializing in chronic disease, complex management, it's still a shame. I joined the U 12 years ago as a pain medicine educator. It is quite an experience in walking into complicated curriculum management. I'll speak a little bit about that later. And I also worked with the first opioid guideline committee for better, I think, got lots of complaints. In fact, I was sued for restricting access to opioid requiring patients. Worked with the CDC, worked with the webinar series. I've been mentoring through a primary care network across the Pacific Northwest called Telepain, which we have struggled for funding since the get-go. We're now fortunately funded by the state legislature, but that it requires biannual approvals to keep this program going. I've done a lot of CE activities for REMS, and can speak from the fact of being literally heckled by the audience, claiming that I was shilling for the pharmaceuticals. And even the perception of a conflict of interest is enough to discourage interest and activity. And much of what has been said, I certainly agree with in terms of the mandatoriness of the requirements, and also the focus on opioids when it comes to pain. More on that in a minute. And been involved in the creation of opiate stewardship programs, and worked with Bree Collaborative and other policymaking entities that represent a policy issue. So I have a certain interest to move this forward, a clear interest, and would look to some good outcomes of this important meeting. A click of the slide, please. So I want to also say pain is hard. We know that. It's hard for everyone. And I want to reinforce the fact that patients are first. And it is really difficult for them to navigate the system. And we spend often too little time with them. About 7 minutes is spent as a primary care provider dealing with pain when there are 7 other issues to manage, plus dealing with an electronic health record, plus all the health prevention strategies that need to be taken in, and they're inadequately trained. It also affects communities, the providers we've heard a lot about, of course, and that's what we're mostly talking about, health systems, payers, and policymakers. It's difficult, but I see an answer, and we'll be talking about this a bit as we go. Inadequate education at all levels and across professions, pre-licensure, key. I think we talk a lot about readiness to change in the substance use disorder population of patients. When anyone's ready to change, I think medical students, nursing students, PA trainees, and pharmacy trainees are really ready to learn. That's the setting, and we heard about a 60-year curriculum, so we need to maintain a continuous learning environment and a learning attitude that persists. And there's also absolutely insufficient research, which equals funding in pain. There's no dedicated institute at NIH, so we bounce around. We go to NIDA, thank you very much, appreciate that. We go to nursing, we're in integrative medicine. There's a whole host, but there's no place at all for pain to be properly funded, not only in terms of better treatments for pain, but also education outcomes and to develop new curriculum for that. Next slide. So a couple of key points. Chronic pain is best managed with non-drug and non-opiate treatments. That is not part in any meaningful way in the current REMS approach, both for long-acting extended release or for immediate release. Current pain education is insufficient for trainees. We've heard that clearly. It has not changed in the 40 years since I went through my medical school training, except by fighting our way into curriculum and struggling every step of the way. Pain and opiate use are entangled and confounded. Pain does not equal opiate prescribing. That's what the REMS was messaging. So the wrong message by the wrong messenger can really produce a significant challenge. It faces stigma, it faces disparities. Next slide, please. Simply attending a course or passing an exam does not translate into practice competencies. I saw a lot of people during my REMS presentations on their laptops, and I know they were not scanning slides in advance, and many of them were sleeping, yet they got credit. So that number, granted it's a substantial number, it's certainly not a majority of practice, and we need something better, more interesting, and clearly targeted. We heard about that. Introducing and sustaining healthcare provider pre-licensure courses, I mentioned already, is complex, is tightly guarded, and already overloaded, and therefore a call to invoke entities that determine requirements for competency is critical. And it begins at the moment of trainee education. There are many platforms, content, and structures available. One more click, and then I'm going to skip the rest of my slides for the base of time, and we'll be able to wrap around to them in a minute. Disincentives occur when mandatory training is a prerequisite for prescribing. We saw a great presentation moments ago by Kate Nicholson about the experience of providers. That's certainly what we see in our state, in our region. There's a high value of patient education and effective public and policy outreach. It's been alluded to. We heard Penny Cowan bring that up yesterday, that if we forget about who we're teaching, and it's exactly missing the point. We need to teach the patients as well, and that takes time, and it takes different approaches to clinical practice. There's a critical role, again, I want to emphasize, and this may be the best message I can communicate on top of everything else that's been said, is we need to have improved credentialing exams, improved licensing, and improved practice guidelines, and sustained funding and dissemination is needed without industry conflict. And even if it's a perceived conflict, it's still perceived as such, and feels tainted by those who receive it. So one comment I'll make, and we can shut the slides down, is if the pharmacy funding could go better to local educational efforts at the state level, at the institutional level, and at the funding level for research that is not reliant on opiate litigation. The money that states, communities, counties, and even schools are receiving is going to flow from the equivalent of the tobacco litigation lawsuits. If we're looking for farm funding to support programs, I think it should go to those institutions and to the credentialing agencies to support development and advancement of the process of improving education. And I think, again, in agreement with many, the current model of the REMS is not where we need to go. Wrong time, wrong context, wrong messenger. Thank you.
Great, David, thanks very much. And thanks to all the panelists. You covered a lot of ground, a lot of issues. We have a set of discussion questions that were put together to help build on those comments. And I'm going to, I know those were sent around ahead of time and adjust a little bit based on what we've heard, but I do think it's important to start with the sort of the first one, maybe the last one, and really all three of at least three of these that are related to mandatory prescriber education programs via starting with REMS. And the first one on what would make provider education, mandatory education via REMS effective. We've heard a lot about concerns and cautions that might get in the way of effectiveness and might lead to some combination of, checking the box, prescriber disaffection, and potentially increasing the abandonment problems that we've heard about, rather than a focus on really helping patients get appropriate care and preventing opioid and substance use disorder at the same time. A lot of concerns about external pressures that providers are already facing, aside from additional mandatory requirements like being labeled an overprescriber and PDMP or other metrics. So I'd like to just push a bit on what would make potentially a mandatory prescribing program effective. Let's just take it as given that we've heard a lot about cautions. And I'm not saying this would be something any of you would recommend, but what kinds of things would you want to think about if there were considerations in this direction? Does anyone want to start? And this also can get to steps like if any such program was implemented, how do you make sure it's effective? How do you make sure it's having a positive impact and not causing these kinds of adverse consequences? I think have been very well articulated by this panel and previous panels in this meeting.
I've raised my hand, which I actually use the Zoom to do, so I'll pipe up. This is Stefan, and of course, having just given a strong argument against. So the couple things that I think are really helpful for me in my education are connections to local resources, particularly people who can advise me when I don't know what to do. That is to say, when I'm in an education process where I realize that in my own institution, there's an expert pharmacist and a really great opioid safety doctor who thinks about these things at a very deep level, I use the resource because I learn it exists and reaffirm my relationship to it. The second thing that is very important, I think, is the quality of evidence or data presented in any education. So I do think it's important to highlight that oftentimes when we talk about the opioid crisis, because we're also understandably angry about how we got to where we are, there's a tendency to really simplify data and to try to tell a story in which we could just say, point blank, opioids are ineffective for chronic pain, or point blank, 4 out of 5 people with opioid use disorder began with prescribed opioids, which is actually a pretty complicated reference to a 2013 study, which doesn't quite, but sort of does say that thing. So I like education with no slogans and with really admittedly complex data. The third thing that I would say is really helpful to me is a structure in which I understand or learn that there is some safety in continuing to see my own patient who's on opioids, even though they're problematic. That is, if I'm organized around my fears, I tend to have trouble absorbing new information. And when I've seen clinicians who are organized around their fears, they tend to just, whatever the education is, they toss it aside and they say, I don't want to deal with these patients because I'm afraid. And the vectors that communicate the fears are very often not the education program, but all the other vectors. So we need a little correlation of effort. And Dr. Sandbrink said something very important. He said that the messaging in education also has to be not a conflicting message. with other agencies and entities that speak to providers. That's really valuable.
Great. Thanks for those comments. David?
Well, thank you. And I completely agree with what's just been said. We've introduced a model, ECHO model that's been introduced nationally, and we have a telepain model at the UW, which is an ongoing problem-based, case-based learning strategy, which includes a training about a particular primary care focus topic. The primary care providers are the #1 prescribers of opioids. We saw that yesterday. And they want guardrails. They want mentoring. They were not trained anything about this while they were in their medical training years. It's just starting now in the next generation coming out, but it's still quite limited. And they have a chance to present the case here, a multidisciplinary group. It includes a pharmacist, a physical therapist, a psychologist, anesthesiologist, an internist, and an addiction specialist. And we all talk about the case. And we all have perspectives, and they get CE credits, and it doesn't cost them anything. And it's been gloriously successful, but we have no funding that's sustainable in this. So it's a national model. Many entities have done it. The VA, Freedom, you can, I'm sure, speak to the VA ECHO program that I forgot the name of it now. It's been shifted around, but these have been very effective ways to provide continuous mentoring on specific cases. And our students listen in on it and walk out, and they use the word astonished or relieved or amazed that they have access to help once they get finished with their training.
Yeah, I appreciate that focus has been emphasized so much on a focus on patients and the whole person care, not on specific issues. I should say, having been at the FDA regulates medical products, not medical practice. And so it's going to take creative thinking like you're describing to find the best ways to fit that together. Kate?
So as the patient representative on this panel, I want to say that I think it's also important when we formulate training to integrate the experiences of people with lived experience. My background is as a civil rights and disability rights attorney, and one of the big axioms of the disability rights movement is nothing about us without us. And I think it is really important to addressing some of these complexities to also have the input of people who have pain and live with pain. I do think that one of the last panel mentioned the health equity issues, which I think are quite significant. We know there are biases in terms of from studies in terms of how providers sort of rate the pain of, for example, of Black and Latinx Americans as being less severe. And then given the way we've waged the drug war, people have less access to medication as well. We know that often people with disabilities face heightened barriers to care. And sometimes those with the severest pain conditions are not really represented in studies. So a lot of the studies about the efficacy of opioids really relate to people with sort of more moderate or common chronic pain conditions. And so there's a sort of lack of representation in treating people with rare diseases, a lot of whom are in my group. But I would also say in my group that people with sickle cell or those who are Black who have cancer and other serious diseases have faced greater experiences of barriers of the sorts that I talked about. I also just want to say that I agree with Stefan that one of the nice things about this panel of the last 2 days has been a fairly accurate representation of the current state of the crisis. And I think it's really important for any educational effort to keep up with where we are and provide, all discussions around drug policy, regardless of what the area is, are always a little bit more inflamed. And I think it's really important to keep to the data and keep focused on the real needs of patients with pain, but also the real needs of patients with addiction and people who use drugs.
Thanks for those comments. And that I think connects back to the other comments we've heard about making sure we're getting to patient perspective in these educational efforts. Friedhelm?
Yeah, I was just going to add on in that regard to what Kate just said. I think too often we don't really listen to the patient, right? We make assumptions as clinicians, right? It's not, I mean, we may even start and we teach our providers to do motivational interviewing, But we have to be even first. I mean, where are you coming from? Somebody who is on opioid medication, we cannot assume that they want to stay on or that they want to come off or whatever it is. We have to talk to them. And I think that's part of why you said you're not, as FDA, you're not regulating practice, but part of the training that it has to be. And I think the CDC has done that very well with their guideline is emphasizing the dialogue with the patients and understanding where they are and supporting them appropriately.
Thank you. So I really appreciate these comments about both the challenges of moving forward with any kind of mandatory program and lessons that apply more broadly. I do want to go back to, I want to end, and we've still got a few minutes left. I have a comment on that too. But before we get to, I want to end with like looking ahead to what would make an ideal program. We have several discussion questions essentially related to that. But before we go there, we've also heard, despite all of these opportunities to do better, that just in terms of some of the basics, while there have been improvements in issues like reducing high dose prescribing, reducing the number of pills and so forth, as you all just talked about, which seem like are at least in part due to some of the educational programs, there's still some gaps, some issues with some providers still in that dimension. We've heard about big problems around appropriate tapering. These seem like more on the basic side that you'd like to providers broadly to be able to master. And we talked about this theme yesterday and earlier today too, but are there any basics that you all think that we're missing that we really should focus on? Things like appropriate tapering and appropriate levels of prescribing for new and intensity of prescribing for new patients.
I'll jump in as long as there's a moment of silence here. I think that the key is the term academic detailing that came up. It's very, very time consuming, but if it's built into your health system, it's automatic. If you're working in a clinic, for instance, that as a social worker, in my view, one of the key people in the pain management team, because as we saw from Stefan's presentation, the psychosocial and the economic strategies that people can barely cope with and add pain on top, it's an intolerable condition. So if you have those folks around, it can be disseminated. So people need to be trained in an interprofessional environment. So a training program that does not include the whole team is an ineffective messenger, because when you deal with the other components of the team, you don't know who they are, what they know, and you don't think they know anything until you sit in a room and listen to a pharmacist just kill you on a subject that you thought you really covered, or PT just get it completely right when you had it wrong, and most importantly, psychologists and social workers. So I think interprofessional team education, not just at the student level, but introduce it then when they are ripe to learn about that. I had a come to moment when I went to the pain clinic and these brilliant people were sitting there when I was in my training years. And the person who ran the meeting was a clinical psychologist, followed by a physical therapist, and the docs didn't say a word. And we worked out and we all came out better as a result of it. So just the experience of sharing each other's knowledge and perspectives is critical. So REMS focused on all healthcare providers in this circumstance. And as Kate said, and a patient present to have these discussions is the way we have to do the training. Not with a talk to, listen to, walk out 2 hours later and say, thank God I got that done.
Thanks. Any other comments on making sure that there aren't basics that are missed? Daniel, did you?
I see Friedhelm has his hand up.
Okay, we'll do Friedhelm and then Daniel, and then I want to move on to what does the ideal look like?
I think the core message among others, and I was coming up repeatedly, is that we have to have integrated access to OUD care. We just cannot ignore that. So our prescribers, if you prescribe opioid medication, you must be trained in recognizing opioid use disorder, but also when it's not opioid use disorder, like the case that we heard, and how to address this. But if it is opioid use disorder, that's a life-threatening disease that is treatable. So I find it very hard to accept that somehow we warn our prescribers about the risk of the opioid medication, end up our patients being discontinued, and then there isn't a warm hand of an integrated access to actually provide meaningful treatment of this condition that has been possibly recognized. And that disconnect is something that we have to avoid, and we must provide the training to our prescribers that they recognize their responsibility to make sure that this treatment access is there.
Thank you. We've had a good deal of discussion about what should be a set of core competencies related to pain management, including opioid use and opioid use disorder management that fits into. Daniel, I wanted to go to you.
Yeah, I'll take a shot at where you were headed, Mark, which was the question about the ideal. What would it look like in an ideal?
Okay, that's where I was going next, but go ahead.
So, I think, from what we've learned from the, existing REMS, in an ideal world, we'd have to allow for, a significant degree of curricular flexibility to support those targeted interventions. I think that has come through in a lot of the comments, but, trying to, I respect what you were trying to do, get at the basics that need to be covered, but, even distilling it to that common denominator, sort of ignores the unique needs that individual, learners of different health professions may have, right? So I think at the heart, there needs to be that flexibility built in, which, may be a challenge, but if it's going to be mandatory, that I think will be critical to have an ideal state. Similarly, there needs to be more sophisticated outcomes assessment built in, right? We need to look at measures that provide feedback in a continuous loop that allow these educational interventions to evolve and grow and be more impactful over time. And I think those are two areas that have fallen short in the past, but there's certainly an opportunity to improve if this were to be made mandatory in the future.
Yeah, thanks for kicking off what would be the last part of this discussion. And before I get to the framing the question here, I just want to say it's been a very rich discussion. We've been having some texting on the side, and we're going to try to continue this panel, assuming it's okay with you all, till very close to 4 o'clock Eastern. And then we're going to have a wrap up after that Dr. Hamilton Lopez is going to leave for just a few minutes past 4. So want to make the most of the time we have together, if that's okay with everyone. But Daniel just emphasized something that we've heard throughout, the point about any opioid REMS education program being tailored and targeted into really a systems approach for patient-focused education around how to get the best results for pain management, including opioids. And that really emphasizes that it's not about opioid REMS by themselves, but opioid REMS fitting into a whole ecosystem, which, let's face it, has a number of important gaps. You all have identified them in terms of continuing education from the original clinical training all the way through the continuing development of professionals as they fit into their particular career niche, and as evidence and the context in which they're practicing changes. So that's kind of a tall order in terms of finding a program that is nationally relevant but fits into these diverse settings and circumstances. How can you do that in a way that's not too resource intensive, that can demonstrate impact when we're talking about, as you all have emphasized, some complex systems here? Maybe it's just too hard to make it an opioid education program compatible with this nationwide diversity. So I appreciate your thoughts on what, building on Daniel's comments on what an ideal system would look like, and how an FDA educational program related to opioids and related to the medical products that FDA regulates could fit into it. One clear area of opportunity involves fitting into systems, something that you all have emphasized. David talked about interprofessional teams and education focus there. There are ways that FDA work could connect to that. Friedhelm and David, there are some questions, and I'll just build this in here too, questions from our participants around the opioid stewardship implementation. So maybe to kick this off, you could say a little bit more about that, since people want to know about what that is, and maybe just to push you on this, how do you get programs like REMS education to fit into these systems?
Yeah, it's a great question, and I saw that in the Q&A, and that's a whole essay. So I'll keep it one paragraph.
We need the Twitter version right now.
Twitter, even better than Cliff Notes. No, so opiate stewardship is modeled after antibiotic stewardship. That's the notion. So, there's excess prescribing of antibiotics for useless issues. The pharmacists are paying attention to this. We have PMPs paying attention to a variety of prescribing aspects. And the opiate stewardship programs that have been successful around the country, and I'm pretty proud of the one that we got set up, and I'll be happy to get more involved in that at a longer discussion, involves every single discipline and every single department. And it goes from the supply chain right to the nursing team. And so that's the whole group that are all involved. And it meets on a monthly basis, specific agenda about what topic, and the education occurs in that setting. And they send out a report and they reach out to the relevant entities that are involved. They're looking at data in terms of running out of inpatient medications or an overdose event that occurred in an emergency room based on a discharge. And the office practices, the family medicine people, the PAs are involved. It's a completely interprofessional system-based approach. And if you get the team together, it'll take about a year to get the gears grinding and the lubrication going amongst the group. It becomes a phenomenal educational learning site that then trickles out. So you don't have to have everyone. So the family medicine people talk to their folks, internal medicine people talk to theirs, et cetera. Surgeons are participating. Burn surgery is part of it. Trauma surgery is part of it. ED is a key role. So it's a system that's out there. There's some literature on it right now, but it's a fairly new model of tackling this complex place that has really no place to live, but it can thrive in that setting.
Thank you. And Friedhelm, you may want to add to that, but let me push a little bit further on for our interdisciplinary team-based education programs like this, well enough established, extensive enough that an opioid or other REMS program could fit into them more effectively?
Because you're asking about opioid stewardship more broadly, I think you really, and this is what David was pointing out, I mean, it has to be a comprehensive effort that the healthcare system, whatever, is wherever you practice, right, that addresses by reviewing the pathways, reviewing the policies, directives, and most importantly, facilitates improvements and changes in practice that are geared towards opioid safety. And I think that's what Stefan pointed out earlier, is that if you have an education, you want to link it to the resources that are at your facility. You want to enhance those resources. You want to make sure that they're readily available for patients and for you as provider, and you meant to make sure that people are aware of those. And that is where the education has to link in the practice delivery system. And I think in many ways, when we're thinking about how does a REMS program work, I think there has to be obviously a core education component, but maybe it would work best if the local hospital practice setting has a means to adapt it specifically to their setting and enhances this baby with value by providing access to these resources and how to implement actually what you're teaching locally directly in that setting that the provider is in.
Yeah, and I don't know how feasible this is, but if programs like the ones that you all are describing are becoming more widespread, which it seems like they are, as we do see at least some adoption of these system approaches to pain management and opioid and substance use disorder management, it'd be interesting to think further about whether there's a feasible path to have a REMS program that would work in one way in cases where providers aren't part of such organized systems to provide education support, and maybe a different way where they're not. But I'd appreciate comments from others on this topic, more broadly on the topic of what does an ideal education system look like, and how can opioid-related REMS fit into that. Stefan?
Yeah, just to highlight, I realize that FDA doesn't create mandates for payers, but FDA sits within HHS. HHS has CMS. The CMS can involve itself with payers. So where there are educational gaps and patients with a vulnerability, maybe I have access to a very robust set of services because I have a VA academic pharmacy detailer, but one could at least begin to envision ways in which payers could in fact create a relationship that offers a higher level of training, support, guidance, and problem mitigation for clinicians working with pharmacies. It would require, of course, collaboration from CMS.
Yeah, just speaking as a former CMS administrator as well, opioid use disorder and issues related to pain management are high priority for CMS now, with concerns about equity in this space and concerns about the very worrisome trends that we've already discussed. Maybe there's some opportunities there. Kate?
Yes, in fact, they just put out a nice call for comment to actually, provide payment for medication management, which is a huge beginning, right? So that is a real recognition, and I think a real shift. Obviously, I'm not an expert in medical education. I like the idea of a systems-based approach. I guess I would say, source in terms of comment that, and the sort of context of what we've seen is that these richer interdisciplinary, patient-centered, culturally competent approaches seem to be a better way of dealing with things. Where we've gotten in trouble in this context is with one-sized approaches. Whether that's prescribing opioids to everybody or prescribing them to nobody, right? I mean, we sort of, or setting thresholds and enforcing them as mandates. I think there has to be more nuance and recognition that when you're dealing with issues as big and broad as, for example, chronic pain, which contains all kinds of conditions and different severities and has different iteologies, and really requires different kinds of treatment regimens. And also even, with use disorders, you're dealing with a lot of sort of complex conditions. And it really, I think the focus of the training really has to be centered on the individual and their circumstances.
Kate, I'm really glad that we're coming to the end of we're at the end of our time, and I'm really glad that we did it with your comments, bringing this back, both emphasizing the system point, which seems to be a clear common theme from all of you around what an ideal opioids education and REMS program would look like, something that fits into a real system that focuses, Kate, as you helped us come back to at the end of the session, on what works best for patients. So I want to thank all of our panelists for an excellent discussion. You covered a broad range of issues. I pushed you on a topic that I know people have concerns about, mandatory programs, and you also came up with some really good ideas about potential, hopefully feasible path forward for how we can do better. Thank you all for all the contributions to the panel. And with that, I'd like to turn back to Dr. Hamilton Lopez to close out our meeting.
All right, thank you so much. And thank you all for staying with us to the very end. We just wanted to say a few comments before we let you go. Just reflecting on the last 2 days, last day one, we were very fortunate to hear presentations on the evolving dynamics of the opioid and substance use crisis, as well as FDA's ongoing considerations around the REMS program. And then we also talked about trends and prescribing patterns. It was a broad conversation, but it really got to some of the core issues. We had panel discussions providing more context on the wide availability of provider educational efforts at the federal, state, and health system levels, and considerations for what aspects of the opioid crisis could be alleviated by prescriber education. Today has featured 2 panel presentations where we heard about how to tailor and target education to generate real change in prescribing practices, and some concerns that it may be difficult to include all these principles in REMS. We talked about providers and prescribers that face external pressures, education that cannot be conflicting members from other sources of information to those providers. Also, just talking about how providers want to know that they can continue to safely prescribe opioids to their patients. We considered where it is that the patient might be coming from, that mandatory provider education would provide potentially some additional burdens on patients that have had other bad experiences with not being taken into a provider's practice or being abruptly tapered. There needs to be recognition of equity considerations with certain patients not having their pain acknowledged. Finally, we talked a lot about looking ahead and whether there are considerations for logistical constraints with the mandatory REMS, how we might address those, and finally thought through what an ideal REMS would look like. Mark mentioned this yesterday, and I want to encourage all of you, both participants and audience members, to contribute your comments to the docket that FDA has established to receive input from stakeholders. As a reminder, that docket is open until December 3rd, and the link is in the Federal Register notice for this meeting. This meeting is just the first step that FDA will take in trying to hear from stakeholders on how mandatory prescriber education through a REMS could help mitigate the opioid crisis. FDA expects to hold a future public meeting to contribute to the discussion started today. Lastly, before we go, I want to take a moment to thank everyone involved in putting together this excellent event. First, all of our speakers and panelists who shared their invaluable thoughts and insights with us across both days of the meeting. We had some really productive discussions. I know I learned a lot thanks to all of you, and I'm sure that the audience did as well. I'd like to also thank our colleagues on the FDA planning team, including Gerald Dolpan, Marta Sokolowska, Jana Makinich, Judy Staffa, and Mickey Hunt. And of course, our great team here at Duke Margolis, including Thomas Rhodes, Brian Cantor, Katie Green, Morgan Romine, Ethan Chupp, and Matthew D'Ambrosio. Finally, thank you to everyone who attended. Thank you all for coming, and have a good afternoon.